and National HMIS team senior consultants Ritu Arora ma'am and Ugra Mohan sir, senior consultant, and assistant computer programmer Raju sir. I welcome you all, ma'am, on behalf of Population Research Center. And now I invite Professor B. Muniswamy sir, Honorary Director, Population Research Center, Andhra University. And I also invite Dr. Abhishek Kumar sir, Consultant, HMIS team. Now I hand over the program to our Honorary Director, Professor B. Muniswamy sir. Thank you.
Right. So our beloved Deputy Director General Anjali Rawat, Director Kumara Sundaram, and ministry officials, so dignitaries who came from various states to Visakhapatnam. A very good morning to one and all. So due to a flight technical problem, so our Director General held up at the flight is changed the times. So maybe the madam will arrive. Okay. So sorry for the inconvenience. Right. So due to the technical issue, right, the entire ministry team is coming from Air India in that flight. So due to that problem, so anyhow we are conducting as per scheduled the workshop. Okay. So that's why ministry is requested to, right, Kumar sir from HMIS. So this is 2 days workshop, as you know that. The first day is only for HMIS regarding first day workshop. The second day is only for hands-on experience for Population Research Center officials. So that is how to analyze the data through statistical packages, SPSS and Excel. Okay. So this is the few remarks. Now I invite Chief Guest, the Director General, Ms. Anjali Rawat. Please give your message.
Thank you so much, sir. Good morning to all. And I'm so sorry, due to technical issues in our flight, we are all stranded at Lucknow since yesterday, 4 o'clock. And we are hoping to, depart from here at 2, but not sure because nothing is coming up clearly from Air India. So right now we are in the hotel and we are connecting to this workshop. Since this was the first of its kind, we wanted to have PRC and the HMIS national teams together at one forum so that they can assist each other in the regular monitoring of HMIS data and HMIS new formats which we have launched in the field. So I'm sorry for the inconvenience, but to start with, I would like to congratulate PRC Visakhapatnam for taking this initiative. This is the first time we are holding a regional workshop through a population research center. So thank you to the entire team of Vizag. And I'll be there in the evening. So hopefully I'll be there in the evening. So we have tried to, extend today's session in the evening. So we'll be giving you a break of around 2.5 hours in the middle of the day so that we'll be there by 4:30 and then we can take up few sessions which I wanted to take up physically when we are present. So we'll start the session today with the technical session on the new formats. As you're all aware that we had launched new formats in our annual workshop and we have done a lot of virtual sessions with the states on the new formats. But we wanted to hold this physical meeting so that we can make the PRCs and the national team more clear upon the service formats, service delivery formats which are there in the field. We also want to take a feedback from you because we've already launched, so we want to understand whether you are able to collect the data which is there in the field, in the new formats. So we'll have that feedback session in the evening if we reach there on time. But not wasting much time, we'll just start with the technical session because I have another 1 hour here in the hotel. So one of my team members from here would take the first session. We have rushed Abhishek from New Delhi in the morning, so he'll continue the whole day. And the technical team and my deputy director is also joining virtually from Delhi. So the workshop will continue as it is. The inconvenience caused is highly regretted because it is not in my hands also. But we are meant to be here and we will be continuing with the workshop very seriously. So we'll take the first technical session right away from here itself, and then Abhishek will take over. Whatever feedback, comments, any doubts, we can take that in the evening because we'll be having an extended session in the evening. We'll give you a break in the middle for 2 hours. So that's it from my side. I'll not waste much time because even we have to rush to the airport around 11:30. So we'll start with the first technical session from here. So over to Ritu, and then we can start the session.
A very good morning to everyone. Ma'am has acquainted you of the entire scenario that has happened since yesterday, but the business must go on. So we'll try to go as per the schedule. We are all here, virtually and physically, we are all here. So the first session as per the agenda was HMIS service delivery format. As you are all aware, and we have been discussing on this since the last national workshop, which was held in January, HMIS formats, the data capturing formats, have been revised once again to cover all the new programs of NHM, and the new formats have been shared with everyone. I'll just go through a brief PPT which takes us through the entire process. Many of you would have definitely seen this PPT previously also, but just a second. I hope you're able to see the first slide, which says background data entry format. Someone please confirm.
Yes, ma'am. Yes, ma'am.
So we have basically modified both the formats, the service delivery and the infrastructure formats. The service delivery formats have been modified to incorporate the new programs and schemes of NHM over the period of time when we last revised our formats. We've tried to edit a few data elements to seek more clarity, and the infrastructure formats, which were previously the IPHS formats, have now been modified as per new IPHS to capture certain indicators which are more relevant to our service delivery, so that later on we can go in for data triangulation also. The data reporting on the new format has been started since April 2023. This is what we have been saying, and actually we have done also. For the service delivery format, we have shared the data entry module with all the states, and the states have started data entry also. So service delivery formats, we have increased the number of reporting formats to incorporate medical colleges also this time. We have created a provision for outreach, capturing outreach data also, because many of the states were facing an issue in capturing the services provided in the outreach area. So now if a facility declares that it is providing outreach services, there and then in its format only, they can enter data for the services in the facility and the services in the outreach also. And as far as infrastructure formats are concerned, we have tried to reduce the number of formats here. We have done away with the bed-wise classification. All like DH, initially we had 3 formats, so now it is 1 format only for the district hospital. During the course of day, we will be discussing all of these formats in details, data element wise, which we have done many times previously also, but those were all virtual sessions. So this physical session also, which is now a hybrid mode, we'll try to acquaint all of us with a similar, with all the formats and come on the discussions and whatever things are there. So this, I think I have covered mostly. And this is the summary of the new program and elements which we've added. Like we have pregnant women registration with age distribution is there. We've started capturing data for thyroid tuberculosis for the pregnant women, high risk pregnancy. Institutional delivery is also age-wise bifurcation. Stillbirths have been bifurcated into fresh and macerated stillbirths. Anemia Mukt Bharat is a completely new section which is capturing details about the distribution and of iron, folic acid, and your identification of anemia and their treatment. Lymphatic filariasis, peer educator in adolescent health. NTEP is a completely new section. NACO also we've elaborated. Outpatient details have been increased. IPD, NRC's new elements have been added. Pradhan Mantri National Dialysis Program has been added. NVHCP program has been added in this thing. Maternal death age-wise distribution is there. And then at the end, we have quality assurance and biomedical equipment management and maintenance program. So all of these sections which have been added, as you all know, have been done in great deliberation after a lot of discussions and deliberations with the concerned program divisions. And our team has they tested all the formats in the field, and many of the states present here were also a party to the field testing. Our teams went states opted on their own also to go for this testing, field testing of this. So after multiple rounds, we are very happy to say that the service delivery formats are online. People can now enter data for the month of April. So this is basically the service delivery formats, 6 formats. Apart from that, 6 facility formats, but DHQ and DHQ. So DHQ format was there previously also, but now we have added a block headquarter format. The purpose of it, which mainly is to capture the health services which are not being provided at the health facility, like the services of school health, like the services at Anganwadi. Broadly, they have been, it is envisaged to capture them at block headquarters. All the states are now well aware of block headquarters. Everyone has created the block headquarter unit for data entry. And in fact, we are getting data entry for it also. And then outreach, as I told, is available for all the facilities which are providing services outside the facility, except the medical college. For infrastructure and HR, we have 6 formats. We don't have a bed-wise bifurcation now, so the number of formats has reduced here. This is number of elements, I think, which is not much relevant. This is one very important thing, which is another matter of concern and where we need your help also. Apart from the 6 facility types, we were having 5 initially. We've added a major facility type, that is a medical college. Apart from that, we have tried to categorize the facility into subtypes as per the IPHS classification. That is health and wellness subcenters. All the subcenters and PHCs have been converted to HWC subcenter and HWC PHC. We have further classifications, as the rural ones would be HWC sub SS3R and the urban ones would be UHWC. And if a facility which is a subcenter is not functioning as a HWC, they can be marked as non-functional as HWC. Based on whatever categories the state and the districts in the facility had categorized them, as per an algorithm, we've tried to convert most of them, rather all of them, to one of these category types, and we have been following up with our states to check if that categorization was wrong, was right. If there was an issue, the states were told to correct it. And I hope the corrections for April has been done by everyone. And April data entry is on. So as soon as we get the complete data entry for April, we are ready to open the data entry for the further month. But now all the fields which are these types, subtypes, they have been timestamped. You can timestamp for a month, and then onwards you can start doing your data entry. So now the moment we are expecting, we are requesting states to complete the April data entry so that we can unblock the May data entry also. So this is the facility ownership classification. This does not have any time stamping. So if you want to classify your facility in any of these, the module is available. You can do it. This does not involve time stamping, so you can do it. But these fields, of course, involve time stamping. So whenever your facility becomes NQS certified, you can put it NQS with a date stamp on it that from 1st of May onwards, my facility is NQS. Yeah, it is Kaya 12. Now my facility can be graded or ranked. So my facility is now under PM Abhim, fully IPHS. So all these things are with the timestamp, and we are going to give a separate module. This module is under testing for us. We've tried to build a beautiful module wherein you will not be allowed, you will not be forced to go to individual facility. We have envisaged this like that whenever you go for a single facility type, all of them will be listed in line, and then you can do the entire category mapping there only. So that module is under testing by our team. We've given certain feedback. The moment we get it, we will share it with you. And the other features, these almost we have discussed over this thing, that outreach is there, notional is there, and then digital bucketing right now is not working because we are right now focusing on the simple data entry part, and we are trying to get more reports. We've given you data reporting status so that you can check what is the status of your data entry. And then the fourth point, which is a module for private facilities, our team is working on that also. And then the moment you get live reports, a financial year drop down will be there, in which if you choose the year 22-23, you will get the report for the previous years, and the moment you choose 23-24, you will get the new data elements. All of these things are in the testing mode by us, and then we are actually hoping to give you the things as soon as possible.
So earlier we had notional facility also, both public and private, but now in the new system we have instructed that there will no longer be any notional facility. All facility has to be tagged as physical, and all state has informed accordingly. So national facility has to be like many private facility were clubbed together and it as a national facility. So in the new system, this has not been made. Similarly, as Ritu Madam has said, that the private facility, we are going to give a provision, and the provision will be that the state admin, they will make sure that the only relevant data items they can select, and that data items can be entered. This module is under development, but will soon provide. But already existing data elements, whatever we have developed in the service delivery format, they can enter for the month of April. May month onwards, we'll have the provision for private facility module also. Now after this, now we are going to discuss the service delivery format. I know that the states who are there from HMIS, they already know, and we have already discussed many times. But for the benefit of the PRC team also, we are discussing the service delivery format. And because already service delivery format data entry has started, so all states know that we have. But for the benefit of PRC also, we are going to discuss the service delivery format. And after that, when we will discuss this infrastructure format, which is under development, that will be definitely new for, many things will be new for the state HMIS also. So now we will move to the service delivery format.
Implementation issue.
Yeah, and the implementation issue as such.
Actually, service delivery formats we have discussed for many times with everyone, and now since the formats are for data entry also, so the purpose of this session, as you would have been reading in the agenda also, is the implementation issues. We just want to listen from you any genuine implementation issues that you are facing, because we have as of now frozen the format because till such time we were in the process of doing changes, we were not able to launch. As of now, we have launched the format. It is broadly frozen, but we are open for genuine suggestions. We thought that we will, after 1 year, revisit it, and whatever situations, whatever actual things that you are facing, we'll try to incorporate them also. But as you all understand, if we would have gone into the rounds of iteration of changing the formats, we would have never been able to launch it. So we've launched it as of now, but we will definitely like to listen it from the states. What are the implementation issues that you are getting, and what other suggestions you actually want us to incorporate so that our this new format is also a success, like we have been doing it for HMIS always, with the cooperation of all the states across the country.
So this is the everyone is able to see the this matrix. Can anyone confirm that?
Yes, yes.
Yeah, it's visible properly.
Yes.
Yeah. Okay. Okay. We have already shared this, and I think all the participants must have the hard copy of that. Hard copy of this matrix is already available with the participant. I hope it is distributed to the participant.
All of you, please take it out of the bags if you have it, so that we can, because it's a big matrix, so it is there. And I would request that during the implementation issue discussion for next half an hour that we would bring, whosoever is raising an issue on any of the data elements may please tell the display code of it. Like I am talking of 1.1.1D, so that we can all reach there and then we can discuss on that. So the forum is to the participants. You may please one by one let us know if any implementation issues regarding the data elements or otherwise in data entry, whatever regarding to service delivery, if you are facing, do let us know. अभिषेक आप मॉडरेट कर लो ये सेशन प्लीज. आप कराते जाओ जो अपना फीडबैक देना चाहता है.
This is Nikhilesh from PRC, sir. Hello.
Go ahead.
Yeah. We have just visited the two districts, Dhar and Khargone district in Madhya Pradesh. And what we observed in the data element, this is ANC registration. The only thing which is bothering at the facility level is how to capture the outreach ANC registration. Say, for example, in district hospital Dhar, they have a ANC clinic, and ANCs from all the wards and even from the rural area coming to them. So they are unable to segregate the age of the ANC women. They are also noting down in the register, but they are not able to segregate which is the woman who is coming for the first time and which is the woman who has come after registration somewhere else, maybe for her first ANC checkup or second ANC checkup and third ANC checkup. So ANC registration per se is little bit tricky for them. So how to train them to capture this data properly and completely? That is the basic problem they are facing.
Okay. Let me respond to that. As far as your question is that the ANC registration for outreach is an issue. So yeah, outreach we have provided sub-center and PSC level for all states. For the hilly and difficult states like Northeastern and Himachal Pradesh, we have provided the outreach services at DH level also. However, it is visible for all currently. Based on the request that outreach services are like the immunization services, family planning, regarding ANC services. So those services which are provided outside the facility, they should be considered as outreach services. Those services which are provided at the facility, those services considered as in-facility services. So ANC registration, we have already system of RCS register there. They are also registering the data. All they are like outreach services. They are not in facility. So they are collecting the information. So your question of understanding who are the women and what is the age, they are already reported in the RCS registered also. Age application all.
Yeah.
जो भी services, all the services which are not provided in the facility, but they are provided outside the facility by the staff of that particular facility are outreach. Anemia, Mukt Bharat, pregnant woman, death, whatever age-wise bifurcation is there, we have told the states also. यहाँ भी we have 10 states available. We have conducted 2 regional workshops prior to this also. It is to be collected. Whenever you also go, people say we don't have it. So we have to tell them very politely, now start collecting it. ये फॉर्मेट इसीलिए 2 महीने पहले फील्ड में पहुंचा दिए गए थे डेटा एंट्री से पहले कि रजिस्टरों में लाइनें लगा लो और हिंदी में रजिस्टरों में लाइनें लगा लो और डेटा कैप्चर करना शुरू कर दो. तो whosoever tells you कि हमारे पास डेटा नहीं है तो उनको बोलो कि अपने रजिस्टर में एक्स्ट्रा लाइन लगा लो और ये इनका डेटा इकट्ठा करना शुरू कर दो, क्योंकि टोटल प्रेग्नेंट वुमेन तो डेटा एंट्री कर ही नहीं सकते आप, वो तो फील्ड ही ब्लॉक्ड है. डालना तो आपको एज वाइज ही है. हम अभी डेटा एंट्री भी दिखा देंगे इसके बाद. सो वी नीड टू टेल देम दैट यू विल, जैसे मोहन सर कह रहे हैं कि आरसीएस रजिस्टर में तो वो एज तो आप कभी भी देखेंगे तो एज और पैरिटी कैप्चर करते ही करते हैं. तो आउटरीच जो फैसिलिटी के बाहर हो रहा है, एज वाइज ब्रेकअप हमें चाहिए ही चाहिए. Also supplement to this, we have 9 states available there. Please, someone can supplement to this answer. Are we able to capture this data?
Any state participant, if you want to supplement, is there any issue in collecting the age bifurcation data for ANC?
Any state would like to answer that? Is there any issue with the age distribution for the ANC? No, sir.
So we make any other issue by any other person, any other state. Implementation issues for service delivery regarding data elements, capturing, entering on HMIS portal, any further good suggestion that you want. This first session is mainly for that only.
For the month of April, is there any issue?
So now
Hello?
coming, yeah.
Yeah, I am Bashir from Srinagar PRC.
Yes, sir.
Yeah, our team visited 3 districts for this PIP monitoring. One is Anantnag, then Kulgam, and Gandharbal. What our team found was that the data entry managers and all these program management unit people have received training on these new HMIS formats. They are well acquainted with all these terms, but when we visited the sub-centers, PSCs, and the district hospital as well as the other facilities, it was found basically the data entry operators have been given the training. But this training has not been given to the people who are basically managing the data. For example, we have a lab. The person who is handling the information in the laboratory, those people have not been given any training on these new data elements. Second issue is that these new HMIS formats, we couldn't find these new HMIS formats available at any of the facilities. Even in one district, that is Gandharbal, they have put some more records or more lines in the registers, but the data entry for these new elements has not started in Janaki. So it was not, yeah.
Sir,
Yeah,
thank you. Sir, actually, हम लोग को sir 11 बजे we have to head for the airport. Thanks for your input. I would like to ask the states present over here. The point that has been raised by Bashir sir is very relevant and very important. We have to since the time we launched the format, we have gone for innumerable virtual trainings and this physical trainings also. Our seniors were of the view that we should go for physical trainings. We have been traveling extensively for these trainings, but then this message has to go down. If we are trying to train the state and district level people multiple times, this now by this time the training should have gone down. And in fact, I would support Bashir's thing because the numbers of HMIS team are available on the HMIS portal. We are getting calls on our phones from people asking so means there are cases where the message is not trickled down that April data entry was blocked because new formats were there. So all the states who are present here may please tell us the status of training on new formats down below. In the evening, this is one point. We'll take the feedback in the evening. Thank you, Bashir sir, for raising it. Any other issue like this? All the states may please prepare a status of what is the status of training on new formats for service delivery, for management facility, and for the infrastructure. Until the evening, we will be taking the feedback in the evening. अगर किसी और को
Yeah, in Madhya Pradesh also they have distributed in HMIS format in Dhar district. But in Khargone district, what we observed, they have distributed old HMIS format very recently, PHC and sub-center level.
With the Madhya Pradesh team is not here, but we will just, you are saying Khargone has given old?
Yeah, Khargone distributed old formats.
Okay.
PHC and sub-center. And in Dhar, observed the new formats have reached block level, and from block level then we start distributing. Yeah.
Nikhil, have you informed the state of this thing? कि आपने पुराने फॉर्मेट क्यों दे रखे हैं?
हाँ, आपने डिस्ट्रिक्ट को भी बताया, स्टेट को भी बता रहे हैं। शायद
स्टेट को बताया स्टेट में?
नहीं, स्टेट में तो नहीं बताया, डिस्ट्रिक्ट में हमने जो डिस्ट्रिक्ट डेटा मैनेजर है और इवन जो डीपीएम है उसको भी बताया कि ओल्ड फॉर्मेट का कोई वैल्यू नहीं है, ओल्ड फॉर्मेट को मतलब कंप्लीटली विड्रॉ कर लिया जाए इमीडिएटली, उसकी बजाय न्यू फॉर्मेट की है।
सर जैसे आप ऑब्जर्व किए ना तो मेल आप कर देते नहीं किया तो कर स्टेट को
नहीं। अभी जो डीएच रैंकिंग का जो रिपोर्ट हमने सबमिट किया है उसमें न्यू एचएमआईएस फॉर्मेट के इंप्लीमेंटेशन के पॉइंट्स हमने मेंशन किए हैं, मिनिस्ट्री को ऑलरेडी इन्फॉर्म कर दिया है ना। आपको
स्टेट में किसी को इन्फॉर्म करना है कि खरगोन डिस्ट्रिक्ट में, उसके अलावा भी आपने कहीं पर देखा है कि मध्य प्रदेश में
अभी 2 डिस्ट्रिक्ट ही विजिट किए थे, इसी क्या ऑब्जर्वेशन।
So this is another important point. One was training, and the second one is that all the states should ensure that new formats are available down. अगर आपको लगता है if you feel that it is difficult, please tell them in their login in the download section we have put the new formats. If you are not able to circulate, distribute anywhere, please tell them to take it from the download. Because even we would be having old formats, but the download has the latest formats available. It is a request to everyone to kindly trickle this message. We know everyone is connected on WhatsApp group. Please tell that in their login, go to download section. You will find the service delivery formats there. Please download it from there. Don't use old formats. We will convey the same. And PRC Sagar, it is a request whenever you write to Madhya Pradesh, please copy it to us also.
Yes.
So that we are able to follow it up. And thanks for your input, both from Srinagar and Sagar. So any other input, please, if you could give us such good input so that which help us in HMIS implementation.
Good morning, ma'am. Can I?
Just a second, ma'am. Just a second. Sorry to interrupt you. One more suggestion is there. We had been to MP in the last workshop. There we found that the states have converted things to Hindi. So it is a request to all the states please proactively try to convert these formats to regional languages. That would help you in gathering good data. We have limitations. We cannot. It is a request to all the PRCs who can volunteer and the states who can volunteer. 2 or 3 group of states which have similar language may please join together and do the conversion thing and share with each other. Yes, ma'am. Please, Saji ma'am, बताइए.
Yeah, ma'am, this is regarding one of the district hospitals visited in Tamil Nadu. They have started using the format, but that outreach column was missing in the format they were maintaining in the DH. So I've informed the superintendent and showed him where to download the original format. And there is a confusion whether the outreach should be reported by the urban primary health center in the municipality area or the DH. There is also an ANM for the municipality area. There is a confusion regarding that.
Ma'am, we have Tamil Nadu team here. Tamil Nadu से थोड़ा कर दीजिए. Parnivel ji, please, आप थोड़ा you try to please respond to this. Ma'am, we have Tamil Nadu team there. Please, Abhishek, एक बार Tamil Nadu team से बात करा दो.
Good morning, ma'am.
Good morning, sir.
Actually, in Tamil Nadu team, the outreach services we are using in the 3 formats: HSC as well as urban PSC and CSC. So not in the rural PSCs, madam. Because the outreach services in the HSC area, the VHN services are doing the services in the field level, that captured in the outreach format. So similarly for the urban PSC, urban health nurses are giving the immunization and MCH activities in the field level. That also be collected. So in the CSC form, the mobile medical unit and the other camp details, everything collected in the outreach format. So DH, SDH, they are not at all doing any outreach services.
Yeah, right.
Sir, Mohan said it initially.
Yeah, in fact, in the initially, I have spoken that outreach is not applicable every level in all states.
Yes.
It is applicable at the sub-center and PSC level, but higher level, it is not applicable in all states. And also in the PSC level, it is up to state that they are applicable there or not. So it is up to state. And they accordingly map the facility that they will provide the outreach or they will not provide the outreach. So it's not like mandatory to everyone, to every facility has to be provided outreach. Wherever it is applicable, they have to map accordingly. So accordingly, it is mapped, ma'am, and then the elements of outreach is visible accordingly.
And sir,
So in the stand on HSC and urban PSC, CSCs only for the outreach services.
Yeah.
That's true, sir. That's true. And specific state queries can be handled by specific state scenarios can be told by states only. And if you remember in the initial PPT that we had shown, we had written that SDH and DH have been specifically opened for hilly states. Mohan sir had said it in the initial session also that this is only for a few states who had requested. Otherwise, outreach is available only till CHC level. So that was a request. So whosoever, and we have clarified the definition of outreach. So what else? Any next?
Thank you, Palani ji. Thank you.
Thank you, sir.
Thank you, Sajni ma'am. Thank you, Palani ji. Any other issue?
Can I speak? Ritu? I'm Jyoti here from Dharwad PRC.
Yes, ma'am.
From Dharwad PRC, we have visited 3 districts in Karnataka, that is Dharwad, Koppal and Uttar Kannada. So in the 3 districts, 2 of them have entered only April data. Dharwad has not entered even from April. All the 3 months data, the hard copy is there. They are not able to open the portal also. So they are asking, all the 3 district officials concerned, HMIS officials are not able to open the portal, and they are requesting the training regarding entry to open the portal, as well as certain confusions are there in the data elements. So all the 3 districts, they are not able to enter the data. They have kept only the hard copies with them.
Ma'am, I will like to before the state response, I will just like to tell once again that only April data entry is available right now because we have timestamps. So the moment we have April data entry over, we'll give some time, 1 day for time stamping of May facilities, then we'll open May data entry. The initial phase, because of this delay, this would happen. So, ma'am, people should keep on recording data in hard copy formats or Excel, whatever they want. They can start doing it right now. But the reporting on online reporting is available only for service delivery for the month of March. And regarding the training thing, I would again request the states to kindly go for extensive trainings and extensive information saying that only April data entry is available. Now we'll do May, then we'll do June. We need, whatever we educate you, you should go and educate further. Initial period will have issues. We accept that, but as I said, we have been able to do it. We launched the HMIS 2.0 in 2020, which was COVID year, but we could still do it with the cooperation of states. And this also, it is an extensive format, but we will be able to do it. But yes, we ourselves are prepared that this first quarter or first 6 months will be full of glitches. We'll have confusions, we will have multiple messages. But as of now, April data entry is available. Soon we'll give you May data entry. Then June also consecutively. Trainings may go on and data for 22-23 is frozen as of now. We have only data entry open for April 23. Right now, rest no other data is open.
In fact,
Yeah, after talking to the 3 district officials, what I feel is they are in need of more training.
Yeah.
Training Karnataka team to respond.
Yeah, Karnataka's team will respond. One more thing that I want to add that
Raghu will respond on this.
yes.
So good morning, sir. Good morning, everyone. Actually, we had given training to all the levels till the sub-central, including district hospital, taluk hospitals. If one more round of training is required, we will provide it to them, sir.
And specifically these 3 districts which ma'am is highlighting, Dharwad, Pakur and this Uttar Kannada.
Dharwad, Koppal and Uttar Kannada.
Sure, ma'am. We will train once again to them, including district hospitals.
From any of us, please do inform us, don't hesitate, but do the trainings because good trainings would lead to good data. एक बार खराब data, if we start getting it now, we'll never be able to correct it. फिर वही freezing, फिर वही unfreezing. So please, it is a request to go in for extensive trainings, everyone. Thank you, Jyoti ma'am. Thank you, Raghu.
Thank you.
Any other feedback? These feedbacks are very important for effective implementation.
Hello.
Yes.
Can I say something?
Yes, go ahead.
This is Akram Khan, PRC Pune. Recently, we have visited Mumbai, Bruhan Mumbai suburb. So there we have observed that in the most of the facilities, this data entry operator is just responsible to do all kind of this monitoring of data and all, and most of the elements they don't understand, and in the facilities nobody means no senior officer is dedicated to look into the data aspects. So that is why there is a mess in the data. Actually, in our DS ranking report also we have mentioned many things regarding that, and whenever we are asking for that explanation, most of the senior officers are not able to say anything on that. And moreover, in that district DPMU, there is no monitoring and evaluation officer for the data monitoring and evaluation. So this is the major problem, and training all the facility and all the officers and the data entry operators required training for the HMIS, particularly the new HMIS formats. They don't know anything about that. Recently, they have received the new formats, but they required a drastic training for implementation of this new data entry formats.
This is really very much required. So see, the whole point is that lot of training and capacity holding has to be done at the field level. So the states which are present here should take this oral try to do as many trainings as possible. We are giving you funds under PIP, so utilize them and hold trainings. We are ready to help you wherever possible. I can send my team and we can hold the training. We need to, trigger this format to the lowest level. Make people understand what are data definitions. You need to give them data definitions in your local languages. So that is what the states have to do. And also, I would like the states to give us the status of the trainings which we will be performing at the block level and the district level and maybe at the state level. Whatever trainings you need to give us a plan. Otherwise, if we just hold at this level will not suffice. You have to percolate these new systems, these new data elements, the data definitions down below. And this is a true practical problem which all the PRCs are highlighting because they visit different districts and they have found this. This has been reported to us many times earlier also. And we have also seen the data entry operator is not aware of the data definitions. The MO is also not aware. Something has changed. The formats will come into picture. When is the data freezing? When the data line will be open? So this has to be told. And unless you hold training to tell these things, the proper data collection would never happen. So I would request the states who are present here to please jot down this training schedule so that I can make my people available wherever possible in your trainings. So that would be a request from our side. Yeah. So any more feedback?
So ma'am, this is what ma'am has said is a common feedback. We need to create that orientation. We need to create that ownership and involve our senior level officers, medicos, paramedicos at the facility. Ownership of this HMIS data needs to be there. What else?
One more suggestion here, ma'am. Actually, while visiting Mumbai, we came to know that they have received one letter from the state that private facilities also need to be enter the data into the new format, and the new node has to be created for the private facilities also. But as I said before that there is no monitoring and evaluation officer at the DPMU. So for them also it is very difficult to monitor all those things. So how it can be functional and all. So these are the problems they have reported.
We understand that. We will discuss with the state team also. But our effort now is to, since we are complete capturing the public data, we should increase our coverage and we should go to private facilities and they should actually report rather than creating notional facilities, group of facilities. Our effort is to go now to the private facility reporting individually. So gradually we don't want you to push in for it. No hurries, but please, whenever you do it properly. We'll discuss with the state team and we are trying to put in the facilities also. And we, as I said, we are working on facilities also. That would help them. I think clear them to come because this format is too big, but not too big. But all the fields are not relevant to the private. So we will joint effort from the state and we will discuss once we are there.
Can we because this is too long?
Sir, voice is not proper. Voice is breaking, sir. Ma'am, your voice was also breaking. Actually.
Can you hear me?
No, these.
Yeah, voice is breaking, sir.
The voice is breaking. Since we have to rush to airport, I think all these issues we will discuss in the afternoon.
Yeah.
Okay.
What we do is that we have Abhishek there. So if we continue with the issues, if Abhishek is able to resolve them, he will be able to answer to you. In case things are left, then we can take up in the evening. And we also have consultants from Delhi joining in. So Rita, are you there with us?
Yes, ma'am, I'm there.
So continue with this session. In case there is any difficulty and any point left, Ananda is also there. If it is not able to, you're not able to cover this, then we can do it in the. Okay. There is a. Hello, can you hear us? Hello.
Yes, ma'am. Yes, ma'am.
Okay. Abhishek, I just want to, before we leave and before you continue with the session, just one thing I need to mention to the state. We have a team of Quickstand with us. I think Rishi from Quickstand has joined us, physically present there with you in the hall. He is one person who is appointed by POP Council to assist us in development of tools. Like last year, we had developed validation tools. So this time, and we've also done a behavior study. We've also compiled a coffee table book of best practices, which is ready to be released anytime now. So Quicksand will be assisting us in preparation of a chatbot. So this chatbot initiative, which we've thought would be helping the field, maybe at the state level and then later district and maybe at the data entry level, 3 levels we've decided to help you proper implementation of new formats. So it will give you the basic information of what is HMIS. It will also help you to get the data definition of a data element. At the state level, it may also help you to get the data on the key KPIs of your particular state or district. So this is an initiative we've just thought of. So a Quickstand team is there with you. They would like to have a small session with the team. So Professor Ramana, wherever possible, arrange a half-an-hour session with the team so that all the states can give their feedback how the chatbot should work. And if they want an FGD to be done with 1 or 2 states, that may also be allowed. If my voice is not clear, then Abhishek, you can repeat what I have already mentioned. So state's requirement can be clearly highlighted to the Quicksand team. There would be a chatbot which we are trying to develop this year. This will help us in proper implementation of the new format. In case there is a FGD required with a particular state, then 15 minutes with 2 or 3 states may also be given to Quicksand during the break time. So
Sure.
this is, so this you can, if my voice is not clear, you can highlight to the team.
Okay, ma'am.
And we will here you can continue, and we hope to see you physically. So thank you so much. Over to you, Abhishek.
Okay, ma'am. Thank you, ma'am.
Okay, thank you.
So, is there any more difficulty in the service delivery format? So you may share for.
Okay, good afternoon, ma'am. We are from Telangana. Ma'am, if you can also keep this matrix, ma'am, in the download format in the portal, it will very helpful for the facilities level to understand. Ma'am, second thing regarding this data item-wise definitions, ma'am. So it will help the facility level to understand. If you can also keep in the download option in the portal. Yeah. And they are in the infrastructure का sir. So ये matrix अगर if you can keep it in the portal so that this matrix will not give the whole separate. Okay, fine. Sir. If it is there, the best level can download and you can. It will be there. Yes, ma'am.
Yeah, regarding Maharashtra, good morning all regarding Maharashtra. So here we have some queries from the people who are entering the data. It's mainly related to the human resource. So in human resource data, they are saying there are through Jilla Parishad, through they have this bonded labor also. So now rightly we have this regular contractor. So where do they enter this bonded labor? Outsourcing, should they write it or what? Is it a bonded labor?
Because there are only 3 classifications.
Yeah, that's what I'm saying.
Regular, contractual, and
they have raised this issue. Bonded labors is there, so where should we?
Either they can put in the outsourced one.
Outsource, you are saying? Yeah, okay. This and regarding this other issue, there. So I think there should be one for bonded. That's what I think.
Okay.
And
Next
regarding
one.
this is HIV test that is conducted in district hospital, sub-district hospital. There only rapid test is being conducted. So accordingly, that need to be changed. Positive cases.
text will be
Yeah. That is what the requirement.
At SDH and DH level.
Yeah, SDH, DH, RH level. Okay. Okay. Thank you.
It's nahi, because bonded, it is for the some time being, na? Okay, we will okay. Then we will
Actually,
discuss
these
with
two
the
are
HMIS
quite
division of
different, sir.
NSSRC also. Yes, medical officer is there only. Okay. We will be discussing the infrastructure format after the tea break. Any other questions from?
Now we can take break for tea. You please have a tea outside of the hall, and we'll be assembled after 20 minutes. Thank you.
मैम वैसे तो आपका नहीं
Request all the delegates, please come inside. Volunteers, please cooperate with us. Volunteers. Now I request Dr. Abhishek Kumar sir to continue the next session. Thank you.
Morning, all of you. We will discuss here the HMIS infrastructure format, and this format is also has been revised this time, and there are different the new. Hello. The new formats had been shared also in the WhatsApp group, which is made.
Joint workshop group.
Joint workshop group is there. The new formats of the MIS and the infra has been shared in that. So we will be starting the HMIS infrastructure HR format. The first indicator in this series is the number of sanctioned bed and the functional bed. Earlier we are taking only the total number of sanctioned and the functional bed, but this year we are segregated that in the male female wise and different section also pediatric, NBSU, SNCU like this. So of all we will taking number of sanctioned bed and the number of functional bed. This will come from the facility master directly. So you can see here the remarks column. These two indicators will come directly from the facility master. And we will capture this from the PSC onwards up to the medical college. No, okay. But then we have the category wise bed distribution also. That is the number of sanctioned beds for the male and similarly for the female. So for the male, it is a sanctioned bed and functional beds for the male and the sanctioned beds for the females and the functional bed for the female. Similarly, sanctioned bed for the pediatric, NBSU, and for all of these, the sanction and the functional bed will be captured. So you can see here for the NBSU, this remark has been given in the second regional workshop conducted at the northeastern states. So they are asking, they have given the suggestion to make the PSC onwards to capture the NBSU beds from the PSC onwards. So is it possible to collect the beds for the NBSU from the PSC? Any state would like to comment on this? We got the suggestion from the northeastern states.
Hello. Hello, this is Reena from PRC Sagar.
Yes, ma'am.
We have NBSU beds from CHC onwards, not PHC.
Yes, ma'am, speak.
Yes, I'm speaking. We have NBSU beds from CHC onwards. CHC, in the CHCs, not in the PHCs.
Okay, but in the northeastern states, they are giving the suggestions to make that PSC onwards only. So is it possible to take the PSC onwards NBSU beds?
I think, as far as I know, to date, there are no NBSUs have been sectioned only in CSCs or district hospitals.
Yes.
They are not available at the PSCs. So I don't think that we may be in a position to get this information for the majority of the states.
Okay, we have received this suggestion in the yesterday and the before yesterday because northeastern this workshop is conducted on 4th and 5th only. So then बट वहाँ पे है कुछ कुछ हैं वहाँ नॉर्थ ईस्टर्न में, इसीलिए वो लोग उसको खुलवाना चाहते हैं वहाँ पे. ठीक है. Then the number of sanctioned beds for the SNCU, similarly for the sanctioned beds and the functional beds are we will capture for the SNCU, and this will be captured from the SDH, DH and the medical college. Similarly, ICU beds sanctioned and functional for the SDH, DH and medical college. Then high dependency unit beds sanctioned functional, then NRC beds sanctioned functional from the PSC onwards. Then number of beds in the private ward sanctioned and the functional also. Then the beds in the burn ward sanctioned functional, then the ventilator supported beds for the CSC onwards sanctioned functional, oxygen supported beds, then number of sanctioned isolation beds. These are the beds classification. Earlier in the formats, there is only the sanctioned beds and the functional bed. Now from this revised version, we will capture in the different fields. And these are the beds which are other than the 24/7 beds. Number of beds in the dialysis center, number of labor beds, emergency beds available in the facility, daycare beds, which should be captured from the subcenter level only. Then the OT minor and OT major beds is there. Then they have given the suggestion that OT major beds will may not be taken at the level of PSC. So shall we consider that remark? Number of OT major beds, it should not be captured at the level of PSC. So they have given the suggestion, that's why we are thinking.
It must be after CSU onwards, I think so.
Okay, wait.
In a camp, because camps are organized.
But ये facility की बात हो रही है ना. फिर then other infrastructure services is there. तो जैसे कि पहले भी एक गवर्नमेंट बिल्डिंग था, डेजिग्नेटेड गवर्नमेंट बिल्डिंग, यस और नो. तो ये सब सेंटर से देन अप टू द मेडिकल कॉलेज. फिर अगर डेजिग्नेटेड बिल्डिंग नहीं है, देन व्हाट इट इज रेंटेड बिल्डिंग और अदर रेंट फ्री. Then whether the facility is elderly and disabled friendly as per the provision of the Disability Act, it should be captured from the sub-center level to the medical college. अगर नहीं है, तो what disabled friendly facilities are not provided according to the Disability Act. Then if it is there, then easy access of wheelchair, what it is not provided. Easy access of wheelchair, stretcher, presence of ramp is not there at the facility. Then whether the building is certified as disaster and fire preparedness as per the norm. If not, then क्या नहीं है हमारे पास? Provision of fire alarms नहीं है. Then fire extinguishers नहीं है कि emergency exit नहीं है facility में. And whether the building is the environment friendly as per the norm. अगर नहीं है तो उसमें क्या नहीं है? Rain water harvesting, solar energy नहीं है कि use of low energy LED lightings, energy efficient lighting नहीं है. इतना है. और ये these are the options we are providing in the radio button. You can check either one or two. Because what are the not available is there. Suppose solar energy and LED lights both are not available, so you can check both the. Then the uninterrupted electric supply, this data element has also been captured in the RHS also. Then if uninterrupted electric supply is there, then regular electric supply only is there, or regular electric supply along with the solar panel is there. Regular electric supply along with the inverter, along with the generator, and round the clock pipe water supply is there or not at the different facility level. If there is no, the source of water is not available, then borewell or hand pump, well or river, what it is present, or it should be available in the payment basis as tanker and water gallons. And this is the available of security cameras at the entry gate and exit gate and other critical points. Ki it is available or not. So we are getting the suggestion that it should be present from the sub-center also, because health and wellness center are there. So they have the provision of the camera also. Similarly, prominent display boards of citizen charter, it should be present in all the facility levels. Separate utilities for the male and female. It will be captured at different facility levels for all the facilities. And whether the separate public utilities is available in the OPD area, in the IPD area, or then the suggestion and complaint box available in the facility. It should be captured in at the all levels. Mortuary is available or not at the facility, in the SGA, DH and the medical college. And medical record section also, it should be present in the CSC onwards. These are the data elements is as per the IPHS compliant 2022. PFMS is available at the facility or not from the PSC onwards. So they are asking that to make the CSC also, yes, because PFMS is present at the subcenter level. Is it possible to PSC is away subcenter at subcenter level PFMS is available? What in the sir Tamil Nadu mein? Excuse me sir, Tamil Nadu mein at subcenter level PFMS is available? No, only at the CSC level. Okay. Then skill lab is present in the DH and the medical college. Education and training hub is at the DH and the medical college. Affluent treatment plant from the PSC onwards. Then the residential facility for the staff should be present for the ANM. So it should be, we are giving the three options, yes, no, or inadequate. Then residential facility for the staff nurse is present or not at the facility, and for the doctors and for any other staff belong to that facility. Then all weather motorable road is present or not, yes or no, at all the facility levels from the subcenter onwards. Then the functional telephone and functional computer. Earlier this one is the only telephone and the computer. Now we have changed this data element to the functional telephone and functional computer. And the functional internet connection will be there or not at all the facility level. Now if there are any question related right now up to this, so you may ask. If there are any question related up to now regarding this beds and other HR. Functional telephone slash mobile.
Mobile also can be shown there.
Okay.
Or it is only landline.
And sir?
No, I am asking about functional telephone facility at the facility. Okay.
So this is a landline one only.
Only for landline?
Yes.
Not per mobile? Okay.
Because in the government websites and everybody is giving the landline number only, na? Nobody is giving the mobile number.
Yeah, just can I say?
Yes, ma'am.
Yeah, just a suggestion. Internet connection is there, but there is have visited one CHC Earth, which is on the en route towards the highway. So when if ambulance and all these places are coming, they have no space for parking. Everything is like outside. So if some emergency cases is there, they will take time. So there should be a separate space for that. That's what I understand.
At the level of CSC.
Sorry?
At the level of CSC.
Yeah.
Okay.
Means this is one example I have cited where I have visited because there is no They have the facility of network, but that issue is very dominant, at least in Maharashtra, wherever we have visited. Thank you.
Okay. Yeah. Yes, sir. So please say in the back because online or also they have joined.
For inputs, but they are not using for inpatient admission. It's only for observation.
For the OPD purpose only.
For inpatient bed. So is there any remarks to put, it is only for observation and all, or it is only for?
No, because in the IPHS, there is no such thing that for observation only we are using the beds.
If suppose we are put it in the sanctioned bed strength,
yes,
the bed occupancy rate for the PHC is putting 0.
Yes.
That is the problem. Whether we can show it, the sanctioned
No,
bed.
you have
or
to show the sanctioned bed because there are beds available in the facility. But if there is no functional bed for the IPD, you are using that as a functional bed, na?
Yes.
So you put the.
No, they are using only for daycare and observation.
If a patient comes and if it is a emergency time, means he wants for the whole day, then
so
whole night means
higher
IPD
institutions
purpose.
are available within the 5 kilometers of jurisdiction, sir. So they will refer to
Means
higher
you have the provision for the functional bed.
Yes.
He can opt, but generally he moved to the other facility.
Yes. The utilization for admission is 0. That's why we are. Any remarks we can put? It is only for observation. And all.
ना बात कर रहे हो तो बताना जो वही
No remarks has been given. You put all the beds in the functional because they are means available for the.
अभी बोल रहे थे
No, he is asking for the beds. They are available for the patients, and if a patient comes, it can be used as a functional beds.
Abhishek ji, for this, functional beds have to be given, not the sanctioned beds. In a PHC, sub-health center and CHC.
Sanctioned bed. Will we put it in the sanctioned bed or not, sir?
No, you have
or not, sir? No, you have to bed or not, sir?
No, you have to
Because they do not have the list.
But there are 4 sanctioned bed or not, sir? Bed occupancy rate. Bed occupancy is 0, no, sir. Okay, really. 0, sir. That's
the issue, but you have to give the sanctioned bed.
Okay, really.
Abhishek ji.
Bashir, sir.
Excuse me.
My query was regarding this functional internet connection. At sub-center and PSC level, generally what we have seen is that ANM or the medical officer uses his own mobile net connection.
But right now, there are various health and wellness centers, so they have the internet connections for that.
So it is the one which has been provided by the government. So if that is functional, then only we can write it as
In the health and wellness center, they are providing government
which
internet
has been
connection.
provided by the government.
So that is why we are giving the option that from the sub-center level that it is a functional internet connection is available or not.
Okay.
No, but Abhishek ji, regarding beds, these people at the sub-health center and the PHC do not have anything written on papers that these many beds are sanctioned.
Ma'am, your voice is very low. Please repeat your question. Reena ma'am? Hello, Reena ma'am? Ma'am, your voice is low. Please repeat your question. Any other question till now?
Hello.
Yes, ma'am.
Yes, can you hear me? Hello.
Ma'am, what you are saying?
I'm saying for the sub-health centers and for the PHC, even up to the CHC, there's nothing on record, written record that they have these many number of sanctioned beds. They're only aware of the functional beds.
No, ma'am. Whenever there is a facility, they are informed that these number of beds are the sanctioned beds for that facility. So they are aware that.
Abhishek, these are all kept at the district establishment office, not with these people.
Yeah, ma'am.
Should we take the word from them that this many are sanctioned?
Yeah, Rina madam, yes, that has to be done by the health facility. Okay, what is the number of sanctioned beds? Okay, because all those records are available either at the level of district or at the level of state admin.
Yeah,
They will have,
They are
they
not
will
aware.
see, a lot of people are aware, a lot of people may not be aware. So what they have to do, they will have to speak with those officials sitting at district level or state level and convey, get the information regarding what is the number of sanctioned beds.
Sir,
Nothing
but
else.
one thing is there, when there are no written records, only by the
No, no,
word
no, no.
mouth,
There are
they
written
provide
records.
sanction beds.
Whenever a health facility is created, notification is issued. In that notification, the number of beds sanctioned for that health facility is written. That's there in the administrative documents with the state, with the district. They will have to call out that data and inform the respective health facility and the or the block level officials. Okay, those things are available. है ना? Yeah. Yeah, Abhishek, you can continue. Yes.
Thanks, sir. Any other questions till now? Okay, sir.
1.4.21 फंक्शनल इंटरनेट कनेक्शन इसमें जो है क्या हम ब्रॉडबैंड को लेंगे या मोबाइल डेटा यूज़ को अगर हो रहा है तो उसको भी यस में मान लेंगे?
नहीं, कनेक्शन का क्या है कि गवर्नमेंट भी प्रोवाइड करती है और प्राइवेट प्रोवाइड कर रहा है, तो SWC में कंसेप्ट है कि मतलब इंटरनेट कनेक्शन फंक्शनल है वहाँ पे हर जगह, क्योंकि टेली कंसल्टेशन भी हो रहे हैं, हर चीज हो रहे हैं, तो आजकल सब ऑनलाइन ही हो रहे हैं।
अगर वो पर्सनल अपने कनेक्शन से यूज कर रहे हैं,
ठीक है, फंक्शनल है,
फंक्शनल है,
हाँ,
तो इसको
ठीक है,
yes है।
वो रिपोर्ट कर सकते हैं फंक्शनल। So we are moving ahead. Next section is the services. सर फंक्शनल तो है ना, अब प्रोवाइड कौन किया ये अलग बात। तो फिर वो जो फंक्शनल है वो नॉन फंक्शनल करेगा, क्योंकि फॉर्मेट तो हर महीने उसको भरने का प्रोविजन है। यहाँ बस बात हो रही है फंक्शनल इंटरनेट कनेक्शन इज अवेलेबल और नॉट। अब वो इंटरनेट कनेक्शन कौन प्रोवाइड कर रहा है, दिस डजंट मैटर। देन वी आर मूविंग फॉर द सर्विसेज। These are the screening services available from the subcenter onwards that NCD screen, as in the SWC NCD screening are there. Eye care OPD, eye care screening, oral care screening, ENT care, emergency care, mental, neurological and substance use care. These are the services which will be available from the subcenter onwards up to the medical college. Then the core healthcare services like general medicine is available, consultation, yes or no, general surgery, ONG services, anesthesia, pediatrics, ophthalmology, orthopedics, ENT. These are available at the different level of the facility. ENT, then dermatology and venereology, skin and VD, RDI, STI, oncology, neonatology, cardiology, gastroenterology, nephrology, urology, geriatric, neurology, radiology services is available from the PSC onwards up to the medical college. Then functional CT scan is available or not in radiology services, which is available. Functional CT scan, functional X-rays available or not. Then functional USG, functional MRI. These all are available from the PSC onwards up to the medical college. Then functional
Abhishek,
yes, sir.
मैं जस्ट यहाँ पे बोलना चाह रहा हूँ तो इट मे सो हैपन दैट वन फैसिलिटी मे नॉट इवन हैव अ CT scan. Forget about whether the CT scan is functional or not. So even if the facility is not having a CT scan, in that case as well, the report has to be, the facility should report it as no. Okay. So I just wanted to clarify this. So functionals, having a functional CT scan is one thing. having a CT scan in that facility is something else. So if in case the CT scan is not available for the facility, it's not there in that facility, then the report should be, facility should report as no.
It should be no for that month if
Yeah.
it is not available. Okay. Okay. Then the functional EEG is also there. Emergency and accident and other emergency casualty 24/7 is available or not up from the PSC onwards. Then critical care is available or not from the SDS, DH and medical college. Then in critical care, what is it is available? ICU, SGU or both? Then three option is there from the SDS to medical college. Then pathology services is there or not? Microbiology, biochemistry there or not? Microbiology, dental care, then psychiatry, physiotherapy, physical medicine and rehabilitative services, Ayush service, biochemistry, dental chemistry, dental care. This is the comment we have received for the Ayush physical services, Ayush services. Yes, from the SWC. Is Ayush services is available at the subcenter level? Because they are giving the suggestion that it should be yes from the, they are giving the services at the SWC in the subcenter.
Yeah, at subcenter level.
Earlier, these Ayush
SWC
services were not available, but now what has happened is because of this conversion to health and wellness centers, some of these ISM, the Ayush doctors have been appointed at community health centers, and they are providing the Ayush services in the sub-centers. So probably that may be one of the reasons that these Ayush community health officers may be providing the Ayush services at the sub-centers.
And from the subcenter. Yes, Niklesh, you are saying something.
Yes. Whatever Bashir sir has said, it is true because all the Ayush practitioners working as CHOs, community health officer at subcenters, they may provide Ayush medicines also.
Okay.
Yeah, but that is only limited up to medicine, not other like Panchakarma or other things.
Okay.
Yeah, that is a daycare procedure, Panchakarma and everything, but they are restricted only to prescribing Ayush medicine.
We can ask from the different states. Karnataka, is there any Ayush available at the subcenter level?
Actually, Ayush services means only providing medicine, limited only to providing medicine or the Ayush treatment also. Ayush treatment also.
Ayush services is there.
To be clear, means it need some definition.
No, sir, we are discussing
clarity.
this the service section. So Ayush service is there or not?
Yes.
Sir, in few PHCs, if the Ayush doctor is there in the facility, the services will be provided.
The service will be provided at the subcenter level.
Yes, not at subcenter, at PHC.
No, we are asking for the subcenter level because whether it should be yes for the subcenter level or not. We know that PSC level it is giving.
But I have a question. Are the Ayush medicines available at the subcenter level or not?
For sub-centers converted into HWC, Ayush is there.
Ayush is there at the subcenter level.
Sub-centers converted to HWC.
Yeah. All the subcenters
okay.
will be converted.
Yeah, most of them are converted.
No, that
Sir, may I say something?
Whether medicines are available or not, Ayush medicines come from the Ayush.
Ma'am, we are discussing about the Ayush services, not medicine right now. So Ayush services is available or not? That is the question. And all the SWC at the subcenter level are providing the Ayush services.
Sir, not in Gujarat.
Yes, Gayatri ma'am.
We don't have Ayush services.
Ma'am, your voice is not clear.
So in case Ayush services is not available at
facilities we have visited, they are not available at subcenter level, I'm saying.
then please leave it blank. In the data entry point, you will leave it blank.
Availability of medicine does not arise. Sorry?
In case any of these services are not being given at the designated health facility, then that health facility will leave it as blank. Okay.
Yes,
I mean, it may be like you. It may so. I mean, I wanted to say that in case a state where they have not made it mandatory, they have not made it mandatory to provide Ayush services at the level of sub-center, then they can leave it blank. Okay. In case the state a state is there who has made it mandatory.
Sir, shall we move forward from the IU services? Okay, we are moving forward. Then health and wellness services available from the sub-center to the medical college, whether it is available or not. Fully equipped blood bank as per the Drug and Cosmetics Act, whether it is available at the whether it is available at the DH and the medical from the SDS level. So whether the blood bank is available at the to make the is okay, na? Okay.
अभिषेक जी थोड़ा सा पीछे ले जाना चाह रहे थे।
हाँ।
इसमें जैसे फंक्शनल एक्सरे या यूएसजी की बात हो रही है पीएससी लेवल से ना।
हाँ।
तो क्या ये हम लोग सर्विसेज की बात कर रहे हैं सर्विसेज की बात कर रहे हैं कि वो ट्रिपल पे मोड की बात
सर्विसेज की बात कर रहे हैं
सर्विस पे की बात कर रहे हैं कि वो ट्रिपल मोड पे या आउटसोर्स के माध्यम से अवेलेबल कराते हैं देन यस होगा ना।
अभी ये सर्विसेज का हम लोग सेक्शन कवर कर रहे हैं तो उसमें ये सर्विस अवेलेबल है कि नहीं फैसिलिटी
मतलब सर्विसेज अवेलेबल होना चाहिए इक्विपमेंट की बात नहीं
नहीं अभी नहीं। What sir? And second is SGU. HDU. If both is available, so you can take the both. There will be the option drag down. Drop down option. There will be drop down option. There will be ICU or SGU.
We can take. We can. So what are the available? ICU available means we can take one HDU. There is HDU. There is why it is why it is. I think it is a repeated question.
Maybe because yes or no, or if it is both available, then you can take the both. Yes.
Yeah, both are yes means it's already understood. Already understood, no? It's already understood, no? Why it is?
Because
I think it is that line is not necessary. Both.
Yes, maybe we can skip that both because
Yeah,
if the ICU and SGU is available, then
No,
system automatically.
Abhishek, we need both. We have already discussed that ICU is a separate thing from HDU. So at one place ICU can be there and HDU can also be there, or maybe one of them is available. So we need all three options here to be reported.
But ma'am, sir is asking if one is there, then if one is there, the ICU
If
is available.
only
or SGU
ICU is
available,
there,
then
they
yes.
will. Yes.
If the IC is available, then we can put as in the second question. It should no. It's only available in the ICU. So if it is ICU is not available and HD is available, they put as S. So when the both are S, it's automatically comes no. Then what is the use of that both?
Okay. We will write this. If it is possible, we will remove it. Fine.
Okay, we will think for that both option may be there or not. We should remove that. Okay. Then the blood bank should be available from the SGH or not. It should be available from the SGH level. Na? It's from the SGH level. Na? Okay. Then the blood storage unit is available or not from the CSC level. Then referral services is available or not from the sub-center to the medical college. Then BPHU, block public health unit, is there or not? Block integrated public health are available with hematology analysis center. These both indicators should be captured from the PSC level to the medical services operation that capture from the SDS level to the medical college. That it should be captured in-house mode, PPP mode, and the functional laboratory in the two modes only, in-house and the PPP. Then functional laboratory is there or not? Yes or no? Then any lab test diagnostic center done at the facility from the sub-center to the medical college. And whether it has been done in the in-house mode, outsourced to the government lab, outsourced to the private lab, these three options will be there.
In earlier part, we are also asking the availability of pathology services. Hello?
Functional laboratories.
Yeah, pathology
Yes, sir. Functional
services. Pathology services we are asking. And now we are asking. Yeah.
एक सेकंड एक सेकंड तो आपके पास एक सेकंड रुकिए
Okay.
हाँ सिस्टम आपके पास एक सेकंड रुक जाइए हाँ सर बोलिए
PSC, the functional laboratory, even the PSC also have the laboratory.
अच्छा from the PSC onwards only means lab test will be from the sub center onwards na?
Sir,
level to the medical the mode of the hemodialysis services operation
to medical colleges. There are 16 tests for the PSC, 5 or 6 tests in the HSC level. The HSC level.
So you are saying that it should be come from the sub center onwards.
Yes.
Okay. Yes, Niklesh जी आप क्या बोले थे? जी आप क्या बोले थे? निखिलेश जी आप निखिलेश जी सुन पा रहे हैं? क्या बोले?
Sir, this is breaking.
निखिलेश जी सुन पा रहे हैं? आप क्या बोल रहे हैं? निखिलेश जी सुन पा रहे हैं आप?
Yeah.
हाँ हाँ बोलिए आप
Voice
बोलिए.
is breaking actually. I was just asking, ICU and all those things. You were asking the pathology services is available or not. And again, we are asking functional laboratories there or not. Is it a overlap kind of thing?
Functional laboratory and any lab test के लिए.
नहीं, functional laboratory is available or not, and pathology services is available or not. So is it a overlapping kind of thing?
नहीं फंक्शनल लेबोरेटरी है कि नहीं फैसिलिटी में ये पूछ रहे हैं और फिर लैब टेस्ट तो किसी भी तरीके से हो सकता है या तो इन हाउस होगा या तो हम लोग आउटसोर्स करके गवर्नमेंट लैब भेजते हैं या प्राइवेट लैब तो इसलिए वो दोनों अलग अलग है लैब टेस्ट
ठीक है लेकिन पैथोलॉजी सर्विसेज when we say if it is available
pathology is a specific type of lab test. Okay, pathology tests are specific. उसके बाद भी और भी lab tests होते हैं. Okay, it's not only limited to pathology.
Okay.
So yes, the functional lab is the overall. It's an umbrella kind of thing, है ना? So within that, we may have been asking कि specifically pathology services है कि ठीक है?
Then moving forward, then medico-legal services is there or not from the PSC onwards. Then postmortem services is there or not from the CSC onwards. Then physiological test, in-house, outsourced, both radio button will be provided. Total number of lab tests menu available in the facility as per FDSI 2019 guidelines, whether it is available or not from the subcenter to the medical college. Whether essential diagnostic test as per IPHS 2022 available, whether it is available fully, no, or partial. Then hematology, urine analysis, stool analysis in that. Then pap smear will be conducted in the subcenter or not. From the subcenter to the medical college, sputum collection, histopathology, microbiology, serology, biochemistry, cardiac investigation, ECG, then ophthalmology, endoscopy, physiology, then echocardiography, whether desirable diagnostic test as per IPHS 2022 available. These will be captured from the subcenter to the medical college. But यहाँ पे उन्होंने सजेशन दिया है कि साइड में हम लोग को IPHS 2022 की लिस्ट भी एक बार दिखनी चाहिए कि यूजर को ये पता रहे कि कौन सी सर्विसेज हैं, कौन से टेस्ट हैं जो IPHS 2022 के हैं. तो ये चीज सही है कि नहीं?
हाँ ठीक है क्योंकि we were already asking to different facilities, how much
Yes, just to
IPHS
make the
compliant
handy कि
is your
whether
facility.
कौन सा टेस्ट है कि नहीं तो वो देख
Yes.
सकते हैं यूजर.
Yes. Check
यहाँ तक किसी को कोई
necessary
क्वेश्चन till now? Any question?
No.
Then we are moving for the special clinics are there. AFSC clinics is available or not? तो यहाँ पे PSC onwards हम लोग capture कर रहे हैं. Then MTP is there or not? Then availability of counseling facility on HIV/AIDS, STD, ICTC. This functional laboratory. So because at PSC level there is no so much, huh? Sir, ऐसा तो नहीं है. Functional at PSC level is functional laboratory is there?
Yes, yes, it should be yes.
Okay.
PHC level. Because lab technician is posted at PHC.
नहीं, sir has given already that from sub-center it should be yes, na? We have noted from the sub-center onwards. Then availability of counseling facility on HIV, AIDS, STD, ICTC, whether it is yes or no for all the facilities. Then management of STI, RTI, facilities under JSY, school health programs is available or not. Then disease surveillance and control of epidemics, IDSP, SP and L form only. And यहाँ पे पहले PL and form था, P and L form, लेकिन अब उन्होंने बोला है कि आप S form भी consider किया जाए उसका. So whether it is sufficient to take the PLN only or it is necessary to add the S form also in the
Yeah, at sub-center please always say S form.
What, sir?
Yeah, from sub-center, at sub-center level it is always S form. So S should be
Yes.
for sub-center.
So is it okay to add the S form, na?
Yes, yes.
Okay. Then the support services. Then CSSG mechanized laundry facility distribution in-house or outsource is available or not. Then whether blood storage unit, blood storage bank is available. The blood bank is available and blood bank will be available from the SDH, given from the SDH, DH in the medical college, then DH from medical college, DH 1945. Then the functional medical oxygen gas plant is available or not from the SDH to the medical college. Then medical air is available, oxygen is available, nitrous oxide is there or not. Suction is available at the facility from the PSC onwards to the medical facility, from the PSC facility, from PSC onwards to the medical college. Air handling unit available or not from the CSC to the medical college. In the air handling unit, there is option handling unit for OT, whether there is option for is available in OT, whether it is there is option available in OT, ICU or any other. Then this is a different one. Central air conditioning is available from the CSC onwards. Diet provided by the hospital. It should be captured from the PSC to the medical college. Ambulance medical college. Ambulance service is accessible within the golden hour. That is 1 hour for the patient from the catchment area. 1 hour for the patient from the catchment area. Then is HIS. This is the hospital information system is implemented. This is the hospital information system implemented at the facility. This is the hospital information system is implemented at the facility level. So it should be yes from the CSC only. Yes from the CSC onwards. Then computerized hospital information system is available, functional in all departments. So whether it is functional in OPD, IPD or pharmacy, laboratory, from PSC onwards only. Okay. And that is the computerized also, na?
Yeah, in this actually this 25.13 AB. For OPD it is okay, but IPD what is happening? They have a computerized e-hospital system. Okay. In that they are only admitting the patient through computerized system, but they are not discharging patient through computerized system. So patient discharge is not at all being recorded at any place, at any district hospital or CHC, whatever they are.
Can anyone comment on this? that patient is coming, then they are using the hospital in means
While
computerized
admitting the
system.
patient,
But in the case of
patient, they are registering everything through computerized. But their discharge is totally manual. It is only in the register.
is it practicing like that only?
Yeah.
Okay.
So Abhishek, in that case, they can say put remarks in yes only for OPDs only. They are registering the patients through electronic system, but for rest of the modules, they are not having any computer system. So they can say yes under this OPD option only for those kind of facilities.
Okay.
Okay, rest are not available.
Okay, if it is available for OPD, then
Only
they
for
should yes
registering the patients, they can say yes under OPD only.
OPD only. Okay.
Okay.
Then the availability of drugs is available at subcenter to the medical college or a medical college. Then we come for the biomedical equipments. Equipment for the OPD, functional BP apparatus is there or not from the subcenter level to the medical college. Functional spirometer, functional blood pressure instrument with pediatric cuff, functional fetal Doppler is there or not. Functional CTG machine is there from the CSE onwards. Functional ophthalmoscope, direct or not, is available from the PSC onwards to the medical college. Then functional streak retinoscope, functional percussion hammer, functional auto acoustic emission analyzer is available from the CSC to the medical college. Functional dental chair motorized with panel and foot controlled with up and down movement. Functional mouth mirror, functional from the subcenter to the medical college. From the PSC onwards. Because in the IPHS 2022, it is giving that from the subcenter only, they are providing the dental chair. Okay. That is why they have given the no for the subcenter. Is it
But
true?
Abhishek,
Yes,
some state requested for this dental chair is available at subcenters. Therefore, it was put yes under subcenters.
What
Earlier, it
about
was no only.
what what about the states, whether dental chair is available at the subcenter chair or not, available at the subcenter or not, because we have made the as available at the subcenter or not, because we have made the earlier no only. Okay, we will discuss once again for this. Earlier no only. Okay, we will discuss once again for this. No, we will discuss once again for this. Actually, earlier we are capturing availability is fully available. Available that time. Here we are partial available that time because a number will be because here we are capturing availability is fully available, partial available that time because a number will be because because available, partial available सब आ जाता है number will वो because a number available, partial available सब आ जाता है behind and the head end with the ETC indicator is there or not. bypass CPAP mask catch-on, then general ICU, functional multi-para monitor, the functional multi-ETCO2 measurement available, functional mechanical ventilator, multi-parameter para monitor available from SGS to the medical college. And in that, functional CTG machine is available or not from the SGS to medical college. Special newborn care unit, special newborn care review function it should be captured from the SGS or not from the SGS to medical college. Special newborn care unit, उसमें is available from the SGS to the medical college. functional phototherapy scale are the data element function and functional therapy, data element functional weighing scale. Then for the analysis is available. There are the data element functional weighing scale is available. Digital 3 होना चाहिए, 3 होना digital, 3 होना चाहिए digital, 3 और 1 to be kept in meter, 1 for each OPD and NRC. Functional phantom C is available. 1 for each OPD and NRC is available or not. Functional in phantom meter, 1 for each OPD and NRC is available or not. Functional resuscitation equipment is available from the functional resuscitation equipment is available, and for the NICU, functional care radiant formula is available. Should be not, it should be it can not be captured, it can be captured from the center of the medical college. It can be captured from the center of the medical college. Functional neonatal ventilator, PICU, pediatric functional patient monitor with neonatal probe, functional neonatal ventilator, PICU, pediatric captured from the subcenter to the medical care unit, functional medical intensive care unit, functional ventilator, PICU, pediatric available, functional intensive care unit, functional mechanical, the basic invasive is available, functional
Abhishek, there is one request. We are unable to hear what you are saying. The voice is breaking.
and for the labor room, and for the labor medical function patient monitor with neonatal probe, functional neonatal ventilator, PICU, pediatric intensive care, labor delivery and ventilator. Labor delivery and recovery area, functional labor room is available or not from the PC onwards. So whether it should be here, recovery area, functional labor room is available or not. From the labor room is available at the subcenter level, not sir, only yes. PC onwards. So whether it should be second, here if this is we have yes and yes for no both for this. So whether it should be captured for at the subcenter level or not. These are making subcenter. We have to finalize one format. It should be a yes and no both for this. So whether it should be captured for at the subcenter level or not. Applicable for all over. How it is. It is a basic invasive available. Functional monitor. Then for the liver delivery and subcenter में वो काम करता है, वो सिग्नल में काम नहीं करता है. ये स्पेसिफिक नहीं बना रहे ना हम. अगर वो सर्विस available, yeah, the center हमें कैसी? What I'm saying. So one question is not related to all. लोगों को करते हैं मास्क में. Yeah. हाँ तो जिसका नहीं वो नो करेगा फिर. इसलिए हाँ maybe network issues there. But functional labor है हमारा center पे. Recovery area, functional labor room is available at the yeah. Maybe not. Yeah. Yeah. Who is subcenter? This option is not okay. We have put on so I know we have received yes or not. हाँ करते हैं हमारा सबसे. But in here we have seen that so it is better to keep this. हाँ. तो वही तो it should be functional also. होना it should be functional also. होना it should be functional also. होना नहीं है functional होना चाहिए. नहीं है functional होना चाहिए. नहीं है functional होना चाहिए. तो बस हाँ तो बस functional होगा तो फिर yes होगा. Functional होगा तो फिर yes होगा. It should be functional also. होना नहीं है functional होना चाहिए. बस functional होगा तो फिर yes होगा. Normal और C section अभी बात नहीं कर रहे हैं. अभी normal C section अभी उससे बात नहीं कर रहे हैं. अभी है कि नहीं उससे बात कर रहे हैं. है लेबर रूम अवेलेबल है बस functional होगा तो फिर yes होगा. नॉर्मल और सी सेक्शन अभी उससे बात नहीं कर रहे हैं. अभी है कि नहीं बस उससे बात कर रहे हैं. फंक्शनल लेबर में अवेलेबल है कि नहीं. हाँ तो वहाँ डिलीवरीज भी होनी चाहिए तभी वो फंक्शनल होगा. ऐसा नहीं कि सिर्फ एग्जिस्ट कर रहा है. तो वहाँ डिलीवरीज भी होनी चाहिए तभी वो अगर कोई आएगा नहीं तो फिर सर्विस कहाँ. हाँ अगर कोई आएगा नहीं तो फिर सर्विस कहाँ से देंगे. कहाँ से देंगे. कोई आएगा नहीं तो सर्विस कहाँ से देंगे. वो अलग चीज है. जब कोई आएगा नहीं सर्विस कहाँ से देंगे. हाँ yes because that's what they are अगर कोई saying that it should आएगा नहीं तो फिर सर्विस कहाँ से देंगे. it should yes well because that's what they are saying that it should yes and जब कोई आएगा नहीं तो सर्विस कहाँ से देंगे फिर सेंट्रल लेवल. okay yes sir yes so for the functional labor bed is there on because they don't have facility, so they are saying that it should be yes. It is care labor room. Okay. So for the functional labor bed is there or center? Bed है कि नहीं ये भी जरूरी है. So for then functional feeder Doppler is there or not from the or not है कि नहीं ये भी जरूरी है. Then functional feeder Doppler is there or not from the PSC onwards and functions are also from the RHS. Are also from the RHS. Yes. 1 minute. Yes. There is some network issue. Online participants are unable to hear us. If you can fix. The items are also from the RHS. Yes, I mean, there's some network. कहाँ पे? Computerized. 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 A. Functional levels. A. Functional levels. A.
सर फंक्शनल लेबर रूम या सब सेंटर पे यस होना चाहिए. फंक्शनल लेबर रूम ये सब सेंटर पे होना चाहिए सर. लेबर बेड है लेकिन लेबर रूम नहीं है.
Yes. अच्छा yes. अच्छा yes. ये एक सेकंड निकले से नहीं दक्षिण बोल ये हाँ अच्छा yes.
अभी यहाँ पे ओपीडी आईपीडी फार्मेसी लैब
सब जगह इंप्लीमेंट नहीं तो
नहीं वो क्या करते हैं देखिए उनको कंफ्यूजन क्या हो जाता है. वो कहते हैं हमारे पास तो ओपीडी अवेलेबल है, वो इसको यस डालते हैं. वो ये नहीं देखते हैं कि बेसिकली वहां पे ये मेरा इंप्लीमेंट है कि नहीं.
हाँ अगर ओपीडी के लिए अवेलेबल है तो वो ओपीडी पे यस करेगा, बाकी दोनों में नो कर देगा.
मेरी बात आप समझे नहीं. हमने यहाँ पे लिखा है कंप्यूटराइज्ड हॉस्पिटल इंफॉर्मेशन सिस्टम फंक्शनल इन ऑल डिपार्टमेंट. ठीक है हो गया यस. नाउ इट कम्स टू
वो यस नहीं होगा.
वो देखिए वहां पे होना चाहिए नो जो भी होगा.
उसमें 4 ऑप्शन आएगा जिसमें चेक बॉक्स है कि अगर वो ओपीडी में है तो वहां पे वो चेक करेगा.
ठीक
यस.
तो इनको कंफ्यूज फिर यहाँ पे करता है. देखिए ओपीडी आईपीडी फार्मेसी लैब अवेलेबिलिटी ऑफ ड्रग्स, वो ये नहीं देखते हैं कि वेदर दिस इज इम्प्लीमेंटेड और देयर आर नॉट. दे से वेदर दिस सर्विसेज आर अवेलेबल. जब हमने 2 सारे चेक किए वहां पे यस था, हमने कहा भाई आपका यहाँ पे तो है ही नहीं. वो कहें सर मेरे पास ओपीडी भी है, फार्मेसी है, आईपीडी है.
सर्विसेज का कॉलम ऊपर था, ये हम लोग बस HIS.
तो ये कंफ्यूजन है, ये किसी तरीके से दूर होना चाहिए.
हाँ ये हाँ ये तो ABCD है तो ABCD बनाया है OPD IPD वैसे.
So Abhishek, this ABCD will open when we will say no for the functional in all departments. Then these ABCD will be visible. If they will say yes, the computerized system is available for all the departments, then these 4 options will not be visible.
अच्छा, if you give the checkbox for the all departments, then ABCD will not be appear.
Okay.
If they will say कि we have not completely fully functional hospital information system, then option will be available whether it is available in OPD only or IPD only or pharmacy only or laboratory only. So then they can check where it is available. It means it's not completely functional. Some of the departments are having this computerized system.
Okay, ma'am. हाँ निखिलेश जी आप बोलिए, आप क्या बोल रहे थे? निखिलेश जी are you there?
Yes. लेबर रूम सब सेंटर पे लिखा हुआ है नो, बट लेबर टेबल फंक्शनल लेबर टेबल इज यस.
So for labor room also in sub center there is no specific labor room specially available in the sub-center. It is only the table which is available in the sub-center only. So for labor room, we have kept it from PHC above format because there is a specific room which we call it as a labor room.
So that is why we have given no for the sub-center because there is no specific labor room.
No, but whatever the new sub-center buildings are coming up as per the IPHS design, they have a option, means provision for labor.
And the sub-centers?
Yeah, that's all.
Okay, then we will check once again the IPHS. Actually, we have referred only the IPHS. There it was only given the labor table only.
Labor table.
If it is there for the new buildings, then we can check it again and we will get back to you. Okay.
देन ये जो दो एलिमेंट है फंक्शनल न्यूबॉर्न केयर एंड फंक्शनल इमरजेंसी केयर ऑफ सिक चिल्ड्रन, ये दोनों आरएचएस में भी हम लोग कैप्चर करते हैं. एंड ये दोनों, ये एक है न्यूबॉर्न केयर जो सब सेंटर ऑनवर्ड्स कैप्चर होगा टू अप टू द मेडिकल कॉलेज एंड इमरजेंसी केयर ऑफ सिक चिल्ड्रन फ्रॉम द पीएससी ऑनवर्ड्स. देन ओटी में फंक्शनल ओटी है कि नहीं, यस और नो. देन ओटी टेबल जनरल फैमिली प्लानिंग के लिए है इंक्लूडिंग फैमिली प्लानिंग. देन OT table ortho, yes or no, from SDS to medical college. OT table obs gynae, OT table eye, then OT table emergency. ये सब SDH और उसके ऊपर लेवल के हैं. फिर देन फंक्शनल एनेस्थीसिया वर्क स्टेशन है कि नहीं, अगर है तो कितना स्टेशन है, 1 2 3 4 5. 1 2 3 तक तो CSC ऑनवर्ड्स है और 4 और 5 DH और मेडिकल कॉलेज पे है.
देखिए हमने वहां पे ओटी इट इज जस्ट फॉर PHC, ओके, बट फॉर ऑल अदर थिंग्स इट इज नो. सो व्हाई इट इज अवेलेबल देन
फंक्शनल ओटी
in PHC? Because it should be at least for the OT general, it should be yes for PHC.
बट जनरल जो है वो इंक्लूडिंग फैमिली प्लानिंग है, तो इसलिए फैमिली प्लानिंग वाले नहीं होते हैं वहाँ पे.
Then my question is that is functional OT is available at the PHC? Then why it is available in these categories? No way.
इसमें लेकिन लोग बोल रहे हैं कि इसमें यस करना चाहिए क्योंकि जनरल है.
मैं कह रहा हूँ इसमें यस करना चाहिए.
तो अभी ये कंसीडर हुआ नहीं है,
अच्छा,
बट अभी हम लोग नोटेड किए कि मतलब हाँ यस.
Yes, it should be yes.
Where? Acha, here it should be 2, minor and major. No, because according to the IPHS, there is no such classification at the PSC level.
In many of the PSC, they have minor OT only.
Okay. Okay, we will discuss with the team, then we will inform. Then emergency unit functional triage bed is available from the CSC onwards to the medical college. Then functional multi-para monitor, then functional emergency with ambu bag, mask and other things. Dialysis unit is available. Functional dialysis machine is there or not from the PSC onwards. Functional dialyzer reprocessing unit is there or not. Then radiology unit, functional CT scan, multi-slice और उसमें less than 64 slices and greater than 64 slices. ये तीनों SGH onwards capture होंगे. Then functional MRI, functional 1.5 Tesla, functional USG machine with color Doppler and eco facility is available from the PSC onwards or not. Then functional digital X-ray machine is available or not. Functional mobile X-ray is there. Functional radio visiograph is there or not from the PSC onwards. Functional orthopantom mammogram, OPG, functional mammography, functional C-arm, functional electrosense phallography is there, EEG. Lab diagnostic is there, functional hemoglobinometer, functional greater than 3-part hematology analyzer is there or not. Functional semi-automated biochemistry analyzer is there or not from the PSC to the CSC only. Functional hematology analyzer, yes or no, from the SGS to the medical college. Functional biochemistry analyzer, Then functional microscope. These are, it should be from sub-center to the medical college. But they are saying that it should not be essential at the sub-center level, functional microscope. Whether it is available at the sub-center or not.
सब सेंटर पे तो माइक्रोस्कोप नहीं होता क्योंकि लैब ही नहीं है, लैब टेस्ट ऐसे केवल पॉइंट ऑफ केयर टेस्ट ही होते हैं.
That is why they are asking for to make the no at the sub-center.
Yes. It should be functional microscope at sub-center.
But then the governance section is there. Constitution of RKS is there. Jan Arogya Samiti is there. Then number of Anganwadi centers functional under the catchment area is there or not. Or this has been captured from the sub-center to the medical college. No, for up to the DH
Sir,
level.
Here we are asking number of Anganwadi centers. So why it is yes or no? Yeah. Here we are asking number of Anganwadi centers. Whether any Anganwadi center functional under catchment area or number.
नहीं, number of Anganwadi centers. Center का number चाहिए.
मतलब total 3, 5 numerals.
हाँ, जितने नो नहीं, यस नो में नहीं है. यस नो बस ये कि वहां पे कैप्चर हो रहा है कि नहीं उस लेवल पे सब सेंटर्स.
Okay.
Any question till now up to the governance section? कौन सा? ग्राम कल्याण. So that will be applicable for up to the village level only, na?
What is village level? गांव कल्याण समिति also.
नहीं, आंगनवाड़ी तो अभी तक नहीं था, वो तो इस बार हम लोग ऐड किए क्योंकि इस पे
ना I am just suggesting there is गांव कल्याण समिति.
क्वेश्चंस बहुत हैं आंगनवाड़ी सेंटर्स को लेके, इसलिए वो ऐड किया गया है. Then moving to the HR section, then the administrative staff, clinical staff, DH है उस SDH and medical college पे. फिर nursing superintendent, hospital manager, assistant manager, public health manager, assistant store manager, chief medical, nursing superintendent, superintendent supervisor, nursing in charge, assistant nursing superintendent, biomedical engineer, medical record officer, total medical record assistant, health information management professional, total accountant, finance LDC, statistical assistant. ये हम लोग RHS में भी कैप्चर करते हैं. Then CSSD and laundry supervisor, sanitary inspector and staff, fire safety officer staff, then clerk, data entry operator. ये सब जो हैं वो कुछ मैक्सिमम तो SDH, DH एंड मेडिकल कॉलेज पे हैं, कुछ PSC एंड CSC लेवल पे भी हम लोग कैप्चर करेंगे. अब हम लोग स्पेशलिस्ट एंड मेडिकल ऑफिसर्स, देन टोटल नंबर डॉक्टर, स्पेशलिस्ट एंड मेडिकल ऑफिसर कितने हैं ये ऑटो कैलकुलेट होगा. ये दोनों फील्ड जितना नीचे से हम लोग कैलकुलेट करवाएंगे. फिजिशियन, जनरल मेडिसिन, emergency medicine, forensic specialist, psychiatrist, neonatology, emergency medicine, forensic specialist, EMR specialist, biochemist, pathologist, oncologist, oncologist, enterologist, dental surgeon, आयुष स्पेशलिस्ट. ये सब जितने हैं ये DH और मेडिकल कॉलेज पे तो है ही, बाकी कुछ SDH लेवल पे भी है. देन आउट ऑफ टोटल स्पेशलिस्ट नंबर ऑफ सर्जन एक्सेप्ट ONG, ये भी ऑटो कैलकुलेट होगा, लेकिन उसके लिए हमें नीचे फील्ड्स भरने पड़ेंगे. मेडिकल ऑफिसर, GDMO, MO फ्रॉम द सब सेंटर टू द मेडिकल कॉलेज. देन मेडिकल ऑफिसर SNCU, NICU, MNCU भी है, इसमें ऐड है, वो यहाँ दिख नहीं रहा, ऊपर आप देख सकते हैं इधर MNCU भी ऐड है. देन मेडिकल ऑफिसर SGU, ICU, मेडिकल ऑफिसर डायलिसिस, DH और मेडिकल कॉलेज पे. ब्लड बैंक मेडिकल ऑफिसर इमरजेंसी, मेडिकल ऑफिसर डेंटल, डेंटिस्ट, मेडिकल ऑफिसर आयुष इंक्लूडिंग RBSK, आयुष MO. It should be captured from the PSC onwards. Then out of total medical officer, LSAS trained medical officer कितने हैं उसमें, EMOC trained मेडिकल ऑफिसर, ये onwards भी है, CSC पे भी है, CSC onwards भी है, CSC पे भी है, CSC पे भी है. ये पहले सीनियर रेजिडेंट और जूनियर रेजिडेंट हम ऐड नहीं किए थे, लेकिन फिर स्टेट से ही रिकमेंडेशन आया कि इसको भी हम लोग को कैप्चर करना चाहिए. स्पेशलिस्ट तक टिल नाउ एनी क्वेश्चन?
सर इसमें एक इशू है, पर्टिकुलरली स्पेशलिस्ट. स्पेशलिस्ट में क्या हो रहा है कि कुछ स्पेशलिस्ट तो एक्स किसी फैसिलिटी पे एक्चुअली पोस्टेड है, दे आर प्रोवाइडिंग सर्विसेज एट वाई फैसिलिटीज आल्सो, मे बी once a week or twice a week or maybe thrice a week also. So in that case, what will be reported? It is yes, available or no?
नहीं, वहां पे स्पेशलिस्ट अगर सर्विस दे रहा है तो फिर वहां यस तो होगा.
No, Abhishek,
But person is only
HR
one.
will be reported wherever they are posted.
हाँ.
At one place only.
At one
Maybe
place.
they are providing services. That is the internal arrangements for providing the services. But HR will be provided at only one place wherever they are posted and getting their salary from.
No, madam. Getting their salary and posting is another. There is
Okay,
another
that is
another
also
issue.
two. Okay.
Yeah, because what is happening? X person posted at Y facility, but he is attached to some C facility. So he is getting salary from B facility.
Fine.
But services he is completely providing at
So
C
wherever
facility.
they are posted, they have to be reported at one place only.
Yeah.
Okay.
Means that clarity should be.
Other,
given to the-
we will write it in the definitions also.
Yes.
For HR only. Okay. But it should not be reported at two places. Otherwise, our HR will be duplicated. Okay. Thank you.
यहाँ इंटरनेट
जैसे हमने ये ऑब्जर्व किया है कि बहुत सारे इस डिस्ट्रिक्ट हॉस्पिटल्स में जो एमओज होते हैं, दे आर हैविंग सम स्पेशलाइजेशन इन एनी फील्ड. उनको उसके बदले वहां पे डाल दिया जाता है वो सर्विस देने के लिए, बट एक्चुअली दे आर एमओज. वो सर्विस जो है दैट विल बी कवर्ड कि हाँ ये सर्विस दी जाती है और अवेलेबल है या नहीं.
नहीं, जब वो स्पेशलिस्ट नहीं है तो सर्विस कैसे दे देगा?
No, they are trained in LSS EMOC like that or anything else they are specialized in.
Actually, we are talking about the availability of human resource. We are not talking about here about the availability of services.
Okay.
Yes.
So when we are talking about the availability of human resource, whatever that is providing, we have to go by this and record whether the person is available here or not.
Yes, and if they have got any kind of training like LSS or EMOC, then we have provided two options after
And
this.
in case somebody is deputed but he's getting his service from elsewhere, he is not considered to be here.
He will report on
Yeah,
that facility.
because otherwise you will have double entry.
Duplication, yeah.
Yes.
Then moving ahead to the nurses, paramedical and allied health staff, then CHO is available from at sub-center only. Then health worker female ANM, health worker male MPW, health assistant male MPS supervisor. इसमें से कई सारे RHS के ही एलिमेंट है, डेटा एलिमेंट. हेल्थ असिस्टेंट फीमेल लेडी, हेल्थ विजिटर, MPS supervisor, MPS supervisor female, total staff, MPS supervisor female, total staff nurse, नेशनल मेंटल हेल्थ प्रोग्राम में total staff नर्स, साइकेट्रिक नर्स, जितने साइकेट्रिक नर्स हैं इसमें वो सेवाएं नेशनल है. देन टोटल कम्युनिटी नर्स, जितने मेंटल प्रोग्राम में कितने साइकेट्रिक नर्स हैं इसमें टोटल लैब वो सेवाएं है. टेक्नीशियन, मेंटल हेल्थ लैबोरेटरी टेक्नीशियन, आउट ऑफ टोटल लैबोरेटरी कितने साइटो टेक्नोलॉजिस्ट हैं, साइटो टेक्नीशियन हैं. आउट ऑफ टोटल एलटी ब्लड बैंक टेक्नीशियन, हीमेटो टेक्नीशियन, ब्लड बैंक हीमेटो टेक्नोलॉजिस्ट कितने हैं. देन रेडियोग्राफर, एक्सरे टेक्नीशियन, फार्मासिस्ट, काउंसलर, हेल्थ एजुकेटर, फिजियोथेरेपिस्ट, बॉडी टेक्नीशियन, डेंटल टेक्नीशियन, डेंटल हाइजीनिस्ट, काउंसलर, हेल्थ डेंटल हाइजीनिस्ट. अब यहाँ पे हम लोग ने डेंटल हाइजीनिस्ट के लिए पहले डाला था, ये सब नो है, सिर्फ डीएच और मेडिकल कॉलेज पे ही अवेलेबल रहेगा. बट अब उन लोग का कहना है कि पीएससी से ही ऑनवर्ड्स इसको कैप्चर किया जाए. तो डेंटल हाइजीनिस्ट अवेलेबल होते हैं पीएससी पे, हाइजीनिस्ट अवेलेबल होते हैं पीएससी पे. Psychologist, clinical psychologist, clinical psychologist, dialysis technician, dialysis nurse, dietitian, medical social worker, psychiatric social worker, ECG, EEG technician, optometrist, refractionist, ophthalmic assistant, audiometrician, dermatology, STD, leprosy technician, lab, laundry technician, CSSD technician, स्टोर कीपर हम लोग सिर्फ डीएच और मेडिकल कॉलेज के लिए रखे थे, बट वो लोग बोल रहे हैं कि ऑनवर्ड्स इसको कैप्चर होना चाहिए स्टोर कीपर. तो स्टोर कीपर होते हैं पीएससी ऑनवर्ड्स कि नहीं? तेलंगाना स्टोर कीपर फ्रॉम द पीएससी ऑनवर्ड. Okay.
Is there a sanctioned post for storekeeper from PHC and above facilities?
I was looking at this dialysis technician. For PSC here it is, you know. But when I was looking at the dialysis services, for PSC you have mentioned it, yes. There. So there's a mismatch between what we say at the...
This technician is available from the CSC onwards.
Yeah, but in services section, it is you have shown it available from PSC onwards.
Yes, we have shown from PHC onwards for dialysis.
But here section, then who is providing this?
So we will see this also. We will update it.
Okay.
Another one is that Ayush availability of Ayush medical officer, including RPSK Ayush. That including RPSK Ayush, because RPSK teams are only at block level. They are not facility based teams. They are moving in the block. Every school, every Anganwadi, and so on. So they are not. It's RPSK Ayush should not be counted as facility level Ayush practitioners.
निखिलेश जी एक बार आप फिर से रिपीट करेंगे क्वेश्चन?
Yeah, that availability of Ayush medical officer, including RBSK Ayush. Yeah, but RBSK teams are only at the block level and they are moving in complete block. They are not any facility based teams. So at the most maybe at CHC level.
और ये भी था उसमें एमओ था जनरल जो आप बोल रहे हैं, और ये भी था आप बोल रहे हैं उसमें एक एमओ था जनरल जो आप बोल रहे हैं.
हाँ, Ayush MO at facility is okay, but including RBSK Ayush MO.
हाँ.
RBSK teams are not placed at any particular facility. So that including RBSK Ayush MO can be removed. Only availability of Ayush MO is okay. Or we can have a separate data element for RBSK Ayush. Availability of RBSK Ayush.
So here I have one question. This RBSK Ayush MO are not posted at any of the facility?
Yes, they are only as a team member, moving team throughout the month.
So at block they are not reporting?
No. They are reporting at the block level. They are
block
not
level, no, so
facility
there
level.
will be a block PHC or CHC where they may be reporting.
Only block CHC. At the most CHC. Yeah.
And PHC in some states also. In some state PHC is also a block.
The PHC is also a block, but I think facility and block cannot be taken together. Because block is sometimes very different thing, and block PHC or that may be only nomenclature, I think.
Because some of the states have requested that these RBSK Ayush MO will also be included in these MO Ayush. Therefore, we have included this line item. But as per your feedback, you are saying that RBSK team is not posted at any of the facilities.
Any of the facility, yes.
No. Excuse me, I would like to intervene here. The RBSK MOs are tied up with the CHCs at the block level. They have to report at the block level.
Yes.
And their teams are formed at the block level. So you cannot say that they are just shifting. They are moving in the block. That is a different issue altogether. But they are posted at the block level.
They may be providing services by going
throughout
in
the block.
outreach area.
Block.
Yes.
Yeah.
But they are posted somewhere. Otherwise, how we will calculate total number of Ayush medical officers?
They have to report to the BMO at the block level.
Yes. Therefore, we have included this because this was
It's
requested
perfectly
from
all right.
Himachal
It's
Pradesh.
perfectly all right.
Yes. So please get once again verified that whether it should be included. Otherwise, because of the feedback received, we have included this, including RBSK Ayush MO under this line item. So
Then
still
dental
in,
technician. Yes, ma'am.
No, it's okay.
Richa
You
ma'am,
continue.
are you saying
Abhishek.
something?
Yeah, yeah. Please continue. No, it's fine.
Okay. Okay. Then dental technician. Then maybe this data element has been duplicated. So we will check once. Then coming to the assistant, dental assistant is there or not from the CAC to the medical college, cold chain assistant, assistant dietitian, TSSU assistant, laundry assistant, CSSD assistant, assistant, dresser, PRO, receptionist, GR helmet, facilitator is available at DH and is available at DH and support services, photo support staff, cleaning, guards, food all bearer, gardener is there or not from the PSC onwards, from the PSC dental onwards. Dental assistant, food trolley bearer, gardener is there or not from the PSC onwards. Dental assistant at the PSC level, PSC onwards. Dental assistant at the PSC level. Okay. Okay. So whether it is the available at other states also dental assistant at PSC level. Is available at other states also dental assistant at whether it is available at other states also dental assistant at PSC level. PSC level. Available at other states also dental assistant. Only Goa exception. Only Goa exception. Then support services. Then we have the last section in the only Goa exception. Then support services at PSC level. Only Goa exception. Then support services. Then we have the last section in this. Then we have the last section in this. Quality control इस facility quality control इस facility PRS अंदर कायकल अगर है तो उसका स्कोर कितना है among 1 to 100 places अंदर कायकल control इस facility PRS अंदर कायकल अगर है तो उसका इस अगर है तो उसमें we have the score कितना है among 1 to 100 है कि facility externally access and कायकल नहीं अगर है तो फिर उसका last section in this स्कोर क्वालिटी कंट्रोल इस फैसिलिटी एसेस अंडर कायकल अगर है तो उसका स्कोर कितना है among 1 to 100 इस फैसिलिटी एक्सटर्नली एसेस अंडर कायकल अगर है तो देन कायकल स्कोर देन सुजलम कैंपेन 2.0 इन डेटा एलिमेंट्स इस बार ऐड हुए हैं does a fair external assessment score कितना है and facility have the LWE facility have number 200 इस फैसिलिटी एक्सटर्नली एसेस अंडर कायकल मतलब रेना वाटर है सर्टिफाइड है कि नहीं अगर है तो फिर उसका स्टेट उसका स्कोर देन कायकल स्कोर एक्सटर्नल असेसमेंट स्कोर कितना है उसका स्कोर देन सुजलम कैंपेन 2 पॉइंट है हां वो वहां कैप्चर होगा नंबर वहां ऑप्शन में आएगा अभी हम लोग थोड़ा बहुत और इसमें मॉडिफाई करेंगे जैसे जो भी पोजीशंस आए उसको एक बार डिस्कस करके टीम के साथ देन सर्च को फिनालाइज किया जाएगा डिफाइड है कि नहीं अगर है हां कोई वहां क्वेश्चन कैप्चर होगा नंबर वहां ऑप्शन में आएगा देन सुजलम कैंपेन 2 पॉइंट आईपीएस फैसिलिटीज लेंथ ऑफ द ड्रेनेज सिस्टम 20 एसेंशियल तो ये पूरा इंफ्रास्ट्रक्चर ये नए डेटा एलिमेंट्स इस बार ऐड हुए हैं डज द एजीडब्ल्यू एलडब्ल्यू में इसके लिए हमें वहां को मिलेंगे गाइडलाइंस हमें वहां को मिलेंगे गाइडलाइंस में ये सुजलम कैंपेन के अंदर है रेचा मैम इसका कुछ है GWM LWM
कौन सा अभिषेक प्लीज वो
7.1
वॉइस बहुत ज्यादा ब्रेक हो रही है वी आर
तो फिर फॉलोइंग इसका ये GWM LWM में 7.1
Okay.
सुजलम कैंपेन का
These are the existing data items we have just continued again. We will provide the definitions also. We have that. We will share it. These are all the existing items,
We
Abhishek.
will provide the definition in the guideline only. Definition in the guideline only. Okay. ये हम लोग इस ये इस बार आरएचएस जो कंपास ये इस बार का आरएचएस जो लोग इस HMIS से तो ये इस बार का कंपैरिजन किया गया है जो इसके साथ आरएचएस सभी हुई जो जो कंपाइल हुआ है HMIS से अवेलेबल है और इस साल का जो HMIS निकला गया है अप टू 31 मार्च 2023 और ये लास्ट आरएचएस में ये तब होगा तो इसका कोई रीजन मतलब सडन इतना ड्रॉप कर रहा है फैसिलिटीज देखना है तो सब सेंटर जो अर्बन में थे पहले ये 407 रिपोर्ट हुए थे तो सर ये फिगर सही
Previously, we mapped some of the notional sub-centers in urban area.
Okay.
Those were closed now.
Yes. तो ये 31 मार्च 2023 तो ये छपा हुआ है तो आंध्र प्रदेश में जैसे हम फैसिलिटी देख रहे हैं एंड सिमिलरली फॉर द अंडमान एंड निकोबार ऑलवेज दे आर मिसमैचिंग अराउंड वन फैसिलिटी कभी वो 123 रिपोर्ट करते हैं कभी 124 हर साल एक फैसिलिटी उनकी चेंज होती रहती है SGS DH मेडिकल कॉलेज का ठीक है फिगर्स ये जो है बिल्डिंग पोजीशन सब सेंटर पे जितने भी रिपोर्ट हुए हैं इनके सम कभी मैच ही नहीं करते हैं इसको मैच करवाना पड़ता है मैनुअली तो इसमें जैसे आंध्र प्रदेश में 11070 है तो ये सम कभी मैच ही नहीं करेगा इसके सर जितनी फैसिलिटीज है उसके डिस्ट्रीब्यूशन उसी में होंगे तो अब ये पोर्टल पे तो होगा नहीं ये फिर हम आपको कंपाइल करके आपको जब सेपरेट शेयर करेंगे सभी के साथ तब आपको करना पड़ेगा इसको ये सारे स्टेट्स के साथ है कि सम मैच नहीं कर रहे हैं नहीं मैनिपुलेट नहीं करते हैं मैनिपुलेट करना होता तो मैं ही कर लेता तब आपको नहीं बताता मैं उसको सही करवाना है ना हाँ इस पे मेरे ख्याल से स्टेट ज्यादा अच्छा जवाब देंगे सर कैन यू कमेंट ऑन दिस
See, in portal itself, there is data entry provision. If we select facility, then it should not there should not be provision for for rented building or
there is some loophole in the validations also.
Lower level, they are selecting both the. Even though government provision is available, they selected again it is in a panchayati building or something.
We will rectify this in the new format.
Yes.
Similarly for the PSC also, some is not matching. Only for the Ladakh state it is matching 32 and all are the government buildings. And similarly for the PSC Karnataka, you have to see for all the things. Then HR की अगर बात करें, human resource भी बहुत ज़्यादा dip हो रहा है. जैसे last year आंध्रा में health worker female A&M sub center पे 14,000 थे, अभी ये 13,000 हो गए, तो almost 1,000 का ये gap हो रहा है. तो अगर ये सही है तो सर आपको देखना पड़ेगा स्टेट पे क्यूमुलेट करके कि अगर ये फिगर सही है कि ठीक. नो इन पोजीशन हेल्थ वर्कर फीमेल.
Some maybe recruitments are there. maybe increased.
हाँ नहीं सर डिक्रीज हो रहा है ना 1000 का डिक्रीज हो रहा है नहीं सर नहीं डिक्रीज ना 1000 का डिक्रीज हो रहा है 1000 डिक्रीज हो रहा है
There is a, okay.
डिक्रीज हो रहा
There is a, okay.
है earlier 14,009 was reported
Okay.
earlier 19,009 reported right now 13,000
Yeah, maybe retirements are there. Yeah, maybe retirements are there.
right now 13,000
Yeah, maybe retirements are there. Promotions are there. There are chances.
Similarly, Goa, Karnataka, Kerala, Telangana, Andaman, Lakshadweep will be earlier.
Information may change.
You just check the figure.
Yeah, definitely. Sure.
Health worker female, similarly health people. पहले तो यहाँ जीरो रिपोर्ट था रिपोर्ट अभी कहाँ था अभी कहाँ फिगर रिपोर्ट है तो ये सही सर की रिपोर्ट है ये सही है सर की okay then doctors at PSC level yes sir इसको बस देखना है कि ये फिगर
में चेंज
है सही है कि नहीं ये just check the figure whether ठीक है कि नहीं अगर ठीक है तो we can continue PSC supporting health of female at PSC is that this year it is नहीं बस अगर ठीक है तो we can continue subject next CSC सदन डे फॉर तेलंगाना ये एक बार फिगर्स आपको चेक करने होंगे हम लोग रॉ में पहले 26 साल रहेगा पूरा कंपाइल करके एक बार शेयर करेंगे आफ्टर द वर्कशॉप फिर उसके एक बार शेयर करेंगे आफ्टर द वर्कशॉप शेयर करेंगे आफ्टर द वर्कशॉप फिर उसके बाद वो करेंगे फाइनल देन ऑप्स गाइनी एट CSC लेवल ये ऑलमोस्ट यू कैन ऑप्स जैसे बस तेलंगाना पे ज्यादा डिप हो रहा है देन पीडियाट्रिशियन देन GDMO allopathic similarly 13,000 pharmacists at PSC level
yeah maybe retirements are
at CSC level
promotions are there
CSC level
there are chances to increase or decrease
yes sir
information may
LT at PC at DSC then level
change
you then check the
yeah definitely sure
similarly Goa at CSC level teacher at CSC level ये ठीक है almost CSC level पे थोड़ा ज़्यादा हो रहा है ये CSC level पे almost ठीक है हैं और बाकी almost ठीक है ये बस ये था कि थोड़ा बहुत मिसमैच हम लोग हाईलाइट जो रहेगा फुल में है कि जो रहेगा फुल रिपोर्ट हम शेयर करेंगे एक्सेल में तब फिर आपको पूरा जो रहेगा फुल रिपोर्ट हम लोग शेयर करेंगे एक्सेल में तब बड़ी कीजिए फिर आप पूरा आर्टिकल रिपोर्ट चेक कीजिए अभी तक कोई क्वेश्चन किसी चीज को लेके इंफ्रा या सर्विस डिलीवरी को लेके कुछ कोई या सर्विस डिलीवरी को लेके कुछ कोई भी क्वेश्चन को लेके कुछ कोई भी क्वेश्चन ठीक है अगर कोई स्टेट अभी अपना स्टेट अभी दिखाना चाहता है कि अपना PPT दिखाना चाहता है ठीक है तो कोई एक स्टेट चाहता है डेटा क्वालिटी का तो कोई एक जो स्टेट से मंगवाया गया था जो आके अपना दिखा सकता है कर्नाटका था प्रेजेंटेशन डेटा क्वालिटी के ऊपर और जो स्टेट से मंगवाया गया था जो स्टेट से मंगवाया गया था प्रेजेंटेशन दिन पहले आना चाहिए कर्नाटका था प्रेजेंटेशन डेटा क्वालिटी के ऊपर कौन पहले आना चाहिए के ऊपर कर्नाटका कौन पहले आना चाहिए कम कर्नाटका कम yes
the IP is for the infrastructure means will this yes or no? how can you know how can you know is there any norms for HR drugs for HR drugs? So how can you put whether it is fully how can you put whether it is compliant fully or partially?
जो ISS गाइडलाइंस में है, उस स्पेसिफिक गाइडलाइंस में है, उस फैसिलिटी क्या क्या होना चाहिए, अगर वो फुलफिल गाइडलाइंस
In the previous HR format in first
में है, उस फैसिलिटी
format in the automatically displayed in format. So in the place available previous HR format infrastructure format there will be display
over the information that what are
that is available in the format or not.
they will be able to display over the what is the infrastructure should be there for the ISS compliance.
The format is
No, in online version, when the user is there for the IPS compliance.
the format is
No, in the online version, when the user is there for the IPS compliance. Do the data entry, then IPS compliance. Online version, when the user do the data entry, then in the information on the mouse over, we will get a in the on the mouse over, we will get a that what the guidelines are there. That what the guidelines are there. तो डाउनलोड करके गाइडलाइन में देंगे ना हम लोग. अलग ऑप्शन कैसे देंगे? तो डाउनलोड करके इधर वी विल या तो फिर गाइडलाइन में ही देंगे ना हम लोग. ऐसे माउस ओवर और ऑन द क्लिक डायरेक्ट सेपरेट विंडो वो खुलेगा. ऐसे अलग से ऑप्शन कैसे देंगे? नहीं, इधर वी विल गिव ओवर माउस ओवर ऑनलाइन होनी चाहिए. सेम फॉर्मेट में देंगे. या तो माउस ओवर दे सकते हैं या तो माउस ओवर पे दे सकते हैं या क्लिक पे एक कैसे देंगे? या तो माउस ओवर पे दे सकते हैं या क्लिक पे एक सेपरेट न्यू विंडो खोलेंगे कि उसमें आईपी के लिए विंडो खोलेंगे कि उसमें आईपी कैसे देंगे? या तो माउस ओवर पे दे सकते हैं क्लिक पे एक सेपरेट
in the previous lesson the
न्यू विंडो खोलेंगे
norms also available in the infrastructure format.
कि उसमें आईपी के लिए
So in the plan okay. So we have to put in the sanction with input only. So we the previous lesson the norms also available in the infrastructure format of HR.
Okay.
So we have to put in the sanction and input only.
just
so we can easily compare with the norms whether it is fulfilled or not.
okay, we will discuss diagnostic elements for all things. Okay.
Karnataka revised one.
Where it is?
Previous
no, in the WhatsApp.
similarly for the dress and diagnostics and
Uh, good morning, all. So we are not put the data here because good morning, all. So we are not put the data here because due to time constraint, we are not able to put all the data issues here. So what in the at the state level, we do data issues, check data issues at every month and send it to the districts. So the district people send to the facilities. So once correct, they'll send confirmation through mail to us so that we will be checking that one. What I'm showing here is how we are utilizing the data in our state to improve the quality of the data in HMIS portal. Next slide. Next slide. Yeah. So as per might be everyone be knowing that about PHC grading. So the government of India has provided government grading of PHCs for 24/7, non-24/7, and in that also rural, urban. Some certain criteria have been given. So based on that, we started to work on that, and we are sending that every quarters we will be doing the grading of health facilities. Can you go for the next? So when we send first time, so there will be much data entry will not be there for many facilities, and many facilities have left like OPD, IPDs, and also HR also they have not put like that. So the grade will come down. So when we send them the quarterly basis, so some of the corrections will be made at that time. In HR, infrastructure, everything. So then again, after 3 months, we will compare again and we will check whether the issue has been solved or not, whether they have properly put right now or not like that. So when we started to comparing like the grading of the facilities, the data quality improved a lot. Similarly, sir, the next slide. So Government of India has given criteria for CHCs also. So based on that, we prepare the CHC grading, CS grading. So based on that also when we send, so that right, the facilities also will be seen. So based on the grading basis, there they will be correcting it, and there also the data is improving. So next. So this is about the data. This is about the grading of health facilities in the Karnataka state. So even after that, we are facing some of the issues in HR at the specialist recruitment. That so we are sending it to the principal secretaries also, so that they can take measures on providing the HR position at the facilities. So likewise, composite index. So earlier, Government of India is to do the composite index. There are 16 RMNCH indicators. So based on that RMNCH indicators also, we will be preparing district-wise ranking and sending it to the districts. So once we send to the districts, they will do the same thing in taluka-wise. So once they are doing, they will find out. Can you go for the next slides? So depending upon the 4 life stages of the cycles, the indicators has been designed. So in case of any issues is there at that indicator, they are correcting the data, and the quality is improving in that also. So likewise, we have many portals in the state, which is for which we are providing data from Karnataka, from HMIS portal to the different portals. We have Avalokana portal, which will be used for SDG indicators, for analysis of the SDG indicators, where out of around 32 indicators are from the health department, of which around 11 indicators data is taken from the HMIS portal. There also every month it will be reviewing, and also there is a chief minister's dashboard. There regularly 3 major indicators like institution deliveries, 4 NC checkups, and also fulmination data will be reviewed. So in case of any issues is there, at that time the district people will be informed in the meeting itself, where CE was also present. So they will be in turn review up the facility level, so the data is correcting. Similarly, planning department also using our data for these reviews. Next slide. So, and every program officers, even including maternal health, child health, and immunization, all are using our HMIS data for reviewing. We have another portal, KDP, Karnataka Development Program. Every month we are having we are OPD and data occupancy rates will be reviewed every month. In that also HMIS data we are using. And as the notional facilities are, what earlier we were doing is to collect data from the private institutions that each taluka we created notional unit. there all the facilities were entering the private data. As right now the notional facilities are removed from the ministry level, we are providing separate user credentials to the all the institutions. So we have created now as private still not started for data entry. I think after the government of India provides, we start to capture data from private also. Sir, next.
Raghu, sorry, your slides are not moving.
I think it's not just one. They are sharing.
Ma'am, is it visible now?
I think it's not
Slides.
sharing. We had requested government of India to provide the API and they have provided us. So from there, we have created one API dashboard to review by the principal secretaries and also DCs at the district level. So that is secretaries and also DCs at the district level. So that is already started from March month. So that is also we are using for data validation. This is available up to block level. These are some of the publications which we have printed brochures on HMIS and also RCH portal. In every meetings we'll be printing like this and also providing to the higher officers. In every meetings we'll be printing like this and also providing to the higher officers. The programs like this, both including HMIS, RCH, and also Anmol, we are printing the brochures. Next. So we have for training we have from state level also for training we have from state level also we have some satcom programs through satellite based training also we are providing to all the facilities, and PHC CSC grading as I told we are using, and also sex ratio at birth, and the data calculated from HMIS will be shared to the WCD department, women and child department. They are also reviewing the data, and we have a human development report from planning department. That for that also HMIS data we are using, and every month we compare the live births with the birth registration CRS. So that data also we are providing to them, so that we come to know that there are many still we are not capturing the all the live births from maximum from the private institutions. So that we are at it to clear those gaps also. So this is about the HMIS. So since we are utilizing the HMIS data in all the portals and linking in all the reviews, the quality of the HMIS is increasing day by day. So thank you.
Good afternoon to all. Actually, HMIS data is a very good tool for monitoring all programs actually. And important of our data, we are trained to all health field staff through YouTube also. Awareness of the HMIS and uh, uses of the importance of the HMIS data. To all concerned field staff and monitoring staff also. And next, we are how much utilizing the data, automatically data quality improved in our Karnataka. And already Raghu told, HMIS data is used by higher authorities like our mission director and our principal secretary sir also, and mission director also. Sometime division level review meeting in our health minister also. RCH related indicators like ANC registration and child registration and high risk pregnancies and anemic related. These are all data reviewed our health ministers are also because of prevent the maternal mortality and IMR. And next point is more HMIS data used to review, more the quality of HMIS data gets improved. And weekly twice, sometime daily, a particular district, all medical officers and THOs and Taluka Health Hospital Administrative Medical Officers and district level hospitals also reviewed on HMIS data with our project director RCH. And one request to our ministry team, HMIS in portal freezing option is very much required at state level, so that the data validation can be restricted to be particular time and hence quality gets improved. This is my request, sir. This in our Karnataka, almost HMIS is I think quality improving, but all level we are reviewing on our district level MND managers and taluka level EPMs. They are all coordinating with you, sir. Thank you so much.
Thank you, ma'am.
Thank you.
Any questions, feedback till now?
Yeah,
from
that's
anyone?
hello. Yeah, this is Nikhilaj from PRC. That's very good presentation, madam. And it is nice to see that HMIS data is utilized by higher level officials. I just have queries. How the data of the bordering facilities or district with districts adjoining with the other states, what is the quality of the HMIS data in those districts? And who particularly enters the HMIS data? Is it data entry operator or the health worker themselves?
Sir, in our Karnataka state, we do not have any particular data entry operators at the facilities. We do not have any dedicated data entry operators. So we have nominated some of the persons at the health facility, like lab technicians or sometimes pharmacists are there. So they are entering the data. And we are providing incentives for them. Per month, per facility, around 1,000 rupees we are providing to them for as incentives for entering of all HMIS, RCH, and also we have ASHA. For all those things, we are providing incentive. We are incentivizing them so that the data entry, there is no issue right now with the data entry part.
What about the quality of the HMIS data in the bordering facilities and
Sir,
districts?
as I told, the visits will be done every month by the our district M&D managers. Around 7 facilities they will visit every month. So when they are checking data with the primary register and also HMS data. There also the quality is increasing. So as of I know, when we analyze it, it's around 90% data is accurate in the HMS portals.
Okay.
Thank you.
Any questions or feedbacks till now from anyone? It should be two-way communication, not one way.
Now it's time to break for lunch. So lunch will be ready another 5 to 10 minutes. You please, all of you are requested to please join lunch, and we will be assembled after 50 minutes. Thank you.
I request Telangana state, Tamil Nadu and Karnataka state to sit with him for the discussion for the chat bot. Please.
Hello.
Hello. We will start with the state presentation from the Tamil Nadu state. ठीक है. Okay. Sir, over to you.
Okay. So, good afternoon, sir. So, in Tamil Nadu presentation, I give some general information about the state. I run through that first few slides, and after that we explain. Next one. So actually, there are 38 districts. For the administrative purpose, it is divided into one larger revenue districts divided into 2 health unit districts. So around 46 health unit districts are there for the health administration purpose. Next. So there are 3 hierarchy of that: primary, secondary, and the tertiary care. These are the facilities and HR details of the primary care, secondary care, and the tertiary care details. Next. These are the vital indicators. They compare with India. This is source as SRS 20. Next. Next. These are some comparison that SRS maternal mortality rate. Then next. Next. Then infant mortality. Now it is 13. So our infant mortality as well as the under 5 mortality also 13. But that rural and urban, some classification is there. Next. Next. So this is our report from our HMIS portal. These are the primary care, secondary care, tertiary care. These are all the footfalls average per day. The four services: OP, IP, deliveries, and family welfare services. This is the number, the services by the primary care and secondary care and the tertiary care. Next. So these are all our total facility master, HSC, PSC, private hospital. The private hospitals is now only from this year only added around 2,000 facilities. Before that, we are not entering the individual private hospital report. They pulled into one district report. They created a one notional facility for private institutions. They pulled the report and they entered in that one. So now they all notional facilities are disabled now. So we are in position to enter the facility-wise report in the private also. Next. So these are all the implementation in the HMIS formats. So before the HMIS by the GOI, we have a very good HMIS report in our state portal, the state HMIS portal. So at that time itself, we have collected both the facility and the community-based report. That is, now it is called as outreach report. In the HSC only, we collected an outreach report in our state format. So other things are ISM or institutional services monitoring report from PSC to Medical College Hospital. We captured the report in the state HMIS portal. From the state HMIS portal, so we developed our interface according to the GOI facility-wise report. What are the data elements mapped with the GOI portal? We done the mapping exercise and automatically generate the Excel file and automatically uploaded into GOI portal. After sometimes the modification done by the GOI, so there we are facing some issues. Then we manually enter the GOI report in the GOI HMIS portal. Next. So after, now they are modifying the facility-wise report, adding some new data elements. These data elements, it is not available on the state portal, but the data available in the facilities. not captured in the state HMIS format. So now we have to add in the state HMIS portal. Accordingly, we have to map to GOI portal, GOI Excel sheets. Then we have to push it on to HMIS portal. So based on that, now we are revamping the state HMIS portal also with a new vendor. So once it is stabilized from the state portal to GOI portal, we are planning to move through the data through API. Next. So these are the agreed timelines and the responsibility of the each and every facility-wise report from the data entry to monitoring officers. So first four things are our state HMIS portal. So from the state HMIS, so before 5th of every month, all reports should be uploaded in the state HMIS portal, and the facility-wise who are the responsible monitoring officer, facility level, block level, and the district level. So similarly for the GOI portal, how they are who going to enter the report in the GOI portal. Next. So this is the responsibility fixed for data quality at the block level and the district level. Next. So this is the report monitoring. At the state level, we nominated nodal officer from the each directorate. So frequently, we conducted the meeting and discussing the data quality issues. In our office, there are 6 statisticians are there. We assigned 5 to 6 districts to each one. From the portal, they generate the report every day and found the outliers or data inconsistency with our own developed Excel sheets. That conditional Excel sheet we developed, I showed that. So from that, we generate the report and paste it. It automatically gives some remarks. These are all the probable errors. The performance is there, but not entered in the report like that. So this validation report shared to the districts through mail as well as WhatsApp group. We created one WhatsApp group at the state level with the district officials. So same communicated to our district. The district officials, they created the block level WhatsApp group, then posted them. So then and there, immediately update the report in the GOI portal. Next. So our new format, we distributed the funds to the districts for printing of the facility-wise report. Next. Same things what you told. Next. So one important thing is, sir, we are conducting the periodical training to the district officials with our state training team. So we formed a state training team with our statistician, with the other directorate officials. So last year, we conducted a 2 days exclusive training for the each and every districts. So the day one, first we orient our portal and presented what are the data outliers and the data errors, what are the outcomes. Then online reports generation. So everything detailed for 1 day training. The next day the team visited to the facility. Facility, either for the MIS and infrastructure, grading of the then explain about the grading of the facilities and the DH ranking. So what are the data, their importance, similarly for the district hospital ranking. So recently, the Niti Aayog team visited for 3 districts for a DH ranking, Kanjipuram, Mettur, and Padmanabhapuram. So after completion of the field visit, what are the observation the same day itself, we explain to the facility in charge medical officer or RMO or hospital superintendent. So it is very easy to follow up to correct the report immediately. Next. So last year, that is 2022-23, these are all the categories, these number of persons attended the training. So for all 38 districts, the category of staff, whatever the level, the district level, facility level and block level, these many persons are trained. Next. These are all the some sample validation report which we presented in the training. Next. Next. These are the infrastructure, the outlier reports. Next. 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 So every slide we put the note in the bottom of the slides. So every slide we put the note in the bottom of the slides. It is a self-explanatory. Next. Next. Lab test. So this is the state level training what we conducted. Then next. So district level training. So Coimbatore districts. Next. Virudhunagar. Like that. These are all the trainings our state level team conducted at the district level for the first day. The next they visited the facilities. So these are all the facilities, the verification of the our reports as well as the portal report. Then report and with the source of the register also we verified. Next. 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 So these are all the registers available at this is our Kanjipuram districts. So this is the base registers. So first we verified the report with the register, then report to our portal wise report. So the current year 2023-24, so for the month of April, almost 95% of the reports uploaded. So only few things are there. We are also facing some problems with the uploading of reports and the facilities not available. Some technical issues are going on. So it will be completed soon. Next. So that's all. So the Excel report. Yes.
I don't know if I need this, but the outliers you were presenting right now, how are you identifying those outliers? Are you doing it through Excel?
Yes.
Or how
yes,
are you doing
yes.
it?
There he is showing that the Excel file.
Sure. Thanks.
So this is the Excel. This is the report what we generated from the GOI portal. You simply generate and paste it in the Excel file. So automatically this is the conditional formatted Excel sheets. Once we've pasted the values, there are we category three things. One is delete the value. This is the outliers. There is abnormal value. So if the delivery is not conducted at the facility, but they put some number in the C section, it is totally wrong. So like that value shown as a red. Another things, if the performance is available at the facility, then enter the data. So if the deliveries happened, but the outcome not entered, then it shows in green. The value should be verified and correct the data. This is the probable error. For example, there are two AN registrations and the IFA given, for example, 3 or 4. So definitely you have to give 2 persons. If any backlog means 3 or more, 1 more also can. It's a probable error where it is accepted or not. If it is accepted, it's okay. If it is accepted, if it is accepted, means it's okay. If it is wrong, then you change the report. So like the like that, we then districts. So at the state level, our statisticians are every day the gender data and the placement of the areas. So, then the basic device report they send it. So, any other questions? Then the back. That is the conditional format. So there have an option in the conditional in Excel. So they have an option. So in the conditional in the Excel sheet we have conditional. We can put the row. We can put conditional. We compare with what are the columns and the rows are we can compare. That is available in the Excel format. Okay, sir. Thank you.
Actually, this is the data analysis we want all the state to present in the next workshop or in the coming future. Whenever they will be meeting us, though, they will be presenting this type of data analysis on their data. What's that? Okay. Sir, yeah, now Andhra Pradesh team to PPT. Sir, so which one? Yeah, HMIS workshop 6723. This one is a presentation.
Yeah, good afternoon to all. I also prepared one small presentation regarding our state. Next slide, please. Actually, we appointed at every level HMIS nodal officers from sub-center to state level. Sir, where is it? Yeah. Yes, this one. In the year 2011 itself. So at the sub-center level, ANM and PAC level, CHO, MPHO cadre is there next to medical officer. They are the nodal officers for HMIS portal. At a district level, statistical officer is there for each district. He is the nodal officer for HMIS. At the state level, we are having 3 HODs. One is medical education and secondary level hospital service and one is the primary health center service. 3 HODs, we are having 3 deputy directors. They are acting as nodal officers. Next slide, please. Before that, go back service. The HODs, we are having 3. Yeah. Yes, March 2019, March 2019, in our state we are having only 9,000 facilities. In 3 years itself, the facility number increased to 16,000 because we mapped all private hospitals from the year 2021 itself. Around 3,700 private hospitals we mapped. Already we started reporting the private facility wise in HMIS portal. And we fix the responsibility to the local health personnel to coordinate with the private hospitals and ensure that the complete and accurate data entered in HMIS portal. Then in our state, the sub-centers also increased from 7,000 to around 11,000 and odd. Like that, we have increased around 7,500 in just 3 years time period. So next slide, please. Next. Even though the facilities are increased, we sustained to achieve 100% reporting for the last 5 years. Next slide, please. Next slide, please. Yeah. Coming to the data quality, actually, we are doing in 3 stages data quality checkings. The first stage, we have making corrections. We are making corrections and we are communicating the anomalies of data entry facility wise. Anomalies means the data, as Tamil Nadu said, the data is not applicable to those facilities. Those are the anomalies. First, after the completion of the 100% reporting, we download the Excel data into the Excel format, then find out the completely removable anomalies. So those data is not at all should be reported in those facilities like in facilities. Data facility wise, and that will be communicated to the districts from onward district to the facilities. That will be removed. Like go back, click on the rural PHC wise anomalies. So this is one example. Just I want to show you. See here, it is a primary health center. You should not have any outreach, and it is not having any outreach area. So there should not be any antenatal registration. But here these facilities have reported antenatal registration. If we keep this data, the number of registered antenatal registration will be so high, duplication will be happened. So we remove first stage this type of anomalies at facility level. Next slide, please. So then second stage, we will apply the validation checks. Facility-wise validation checks we apply, just like deliveries and outcome of the deliveries and also birth doses and breastfeed within 1 hour, just like those. Then we will also correct those data validation checks at facility level by communicating the facility-wise data validation checks failed facilities. That also you can see at least that second one. So here, yeah, actually, go out. Yes. See here, one thing. Delivery and delivery outcome. One example, please. Delivery and delivery outcome. Come here, left side, left side, left side. Yes, here. See here, number of newborns weight at birth. It is showing 103%. That means then they are showing more than number of live births than the number of live births weight at birth. See the data. The number of weight at live birth weight at birth is 31, whereas live births are go back. Live births. Go back. Back. Live births. Yeah, there is only 30 live births. 30 live births happened in that facility, whereas live birth weight at birth is 31. So it is completely data validation failed data element. Like that, we apply the data validation to every facility, every data element. We communicate to the districts and they will verify and cross-check the data, registers and correct the data. That is second level validation. Then coming to the third level, it is facility level data validation. We have formed the teams at district level, facility level, and the state level. So every facility level data, we have fixed the norms and targets for every month at every level. For district level team, they have to check 5 PHCs, 10 subcenters, and 2 secondary level facilities every month. Like that, they will conduct the data validation at facility level. Data validation at facility level will be happened with the cross-checking with the registers and reporting reports uploaded in the HMIS portal. Next slide, please. These are all the activities, images of data validation at facility level. Next slide, please. Next slide. So then ultimately coming to the data utilization, we are using the HMIS data at multiple levels, just like Karnataka said. So like every month we will prepare the one monthly key performance indicators bulletin for utilization at all levels from secretary to the district administration. Please click on that. In that report, we will prepare analysis also. Okay. So this is the report. Next slide, please. We compare last year and this year performance for every indicator. Next slide, please. We also prepare district-wise progress. So this is the district-wise progress. So number of pregnant women, sex ratio at birth during month up to the month. District-wise, we will show to the districts. And they will review, collector level review will be happened. At state level also, we will review the districts. Okay. Close it, please. Then coming to the, we also compare the HMIS data with other sources of data. For example, regularly we compare the HMIS data with RCH data because HMIS data is a numerical data, quantity-based data, where RCH data is the name-based record. So there should be comparison between RCH, HMIS, then only we can cross-check the quality of the data. So please click on that. We will compare the indicator-wise, just like old report I am displaying. Like this, we will first time history study. What is the first time registration of ANC as per RCH portal and as per HMIS, what is the first time history? One is the name-based record, one is the quantity-based record. If there is any big difference between these two portals, we will ask the district people and facility level people to cross-check the data. So like this, we are conducting the data validation and utilizing the HMIS data at our state. Okay, thank you very much. You can ask if you have any doubt. Thank you.
Thank you, sir. One second. Thank you, sir. Huh? No. Now Kerala team will show the data quality issues for their state.
Good afternoon all. I am Prabha George, State Demographer in Kerala and also holding the additional charge of State Data Officer in NHM. I'm here presenting the data quality measures via Can I continue? The data quality measures that we are taking every month to improve the quality of our HMIS data. This is an overview of my presentation. Point-wise details will be coming in the next slides. Then, previous one. According to our experience, to improve any data, the first thing is we have to use the data. Then only the quality will be improved. If there is no use for that data, if it is highly quality data, then no use. Then it's waste. So if we try to use the data, then only we can improve the data quality. That's why we are using our data for decision making and also for planning and evaluation purposes. And as a step to improve the data quality, every month we do detailed scrutiny based on our own decided checkpoints. We do detailed scrutiny points and we prepare scrutiny notes and send it to the districts. And also do detailed data validation. And the data is used for monitoring our each and every our programs. We are using the data. Particularly for the family welfare related programs, we are using the HMIS data every month. And based on that, we prepare data of HMIS data. We prepare selected key performance indicators, and based on the value of these key performance indicators, we prepare the fact sheets, and these fact sheets we send it to our secretary's office also. And based on that key performance indicators, we prepare composite index and rank the district. The final one, we prepare manually and quarterly, we prepare reports based on the HMIS indicators also. Now we will check each points in detail. First one is how Kerala is using our HMIS data. Actually, in every month, there is a state medical officers conference is conducting in Kerala. It's a 2 days conference chaired by our Honorable Health Minister and Principal Secretary and our DHS and also the Mission Director and all the senior level officers will be present in the State Medical Officers Conference. And from district side, all the DMOs, that is the head of the districts, and also DPMs will be present in the State Medical Officers Conference. That's a 2-day conference. In that 2-day conference, a half-day section is completely given for reviewing the indicator-based review on HMIS and RCH data. In that half-day section, we present indicator-based review PPTs on to measure the performance of the facilities and also the process. Next. And in that meeting, usually detailed study of the detailed review of family welfare related indicators will be presented in that half-day section. In addition to these family welfare related indicators, every SMO, in every month SMO conference, our principal secretary asks us to do a particular detailed data analysis on a particular topic and present it in the SMO conference. In the previous SMO conference, our secretary asked us to do a detailed analysis on the performance of women and child hospitals in Kerala based on our data. And for that, we took the last 10 years of data of women and child hospitals from the HMIS data, HMIS portal, and did a detailed data analysis, a trend analysis we did, and presented it in the SMO conference. Some of the gaps identified in that in the performance of the women and child hospitals are presented in the previous month's SMO conference that is listed here. First one is we could see that the family planning activities are declining in Kerala, particularly in the public sector hospitals. These women and child hospitals are exclusively for ANC related services and child related services only. So in this hospital, the family planning related activities should be happen. But what we could see that based on the last 10 years data, we could find that family planning activities are decreasing in the women and child hospital, and we have flagged that issue there in the SMO conference. And based on our presentation, state government decided to appoint a nodal officer in the women and child hospital exclusively for conducting the family planning activities. And a 2-day training workshop was given to the medical officers in the women and child hospital on the family planning activities. And also, in that study, it was noticed that number of newborn babies in Kerala has been decreasing significantly for the past few years. And in the incoming SMO conference, that is in this month SMO conference, principal secretary asked a sales study of percentage in this month's SMO conference. What the study and so in the Vilaksar hospital study, we could see that on it also showed that in terms of anemia is pregnant women is increased and also and based on that the also. And based on that, decided to now the state government is implementing a campaign known as Viva. Viva is a Malayalam word. Vilarchayil ninnum valarchayilekku. That is a Malayalam word. That means from anemia to growth. And that campaign they have decided to do in a faster way, because now that anemia program is being implemented in Kerala. And based on our point, that is the WNC hospitals also showing that prevalence of anemia among pregnant women is increasing in Kerala. So based on that input, the state government decided to improve the coverage of that Viva campaign. This is the snapshot of present what we are doing in the SMO conference. This is and based on the data validation, facility level data is scrutinized every month in detail at the state, district level, and scrutiny notes are prepared and given to the blocks. And also, online review meetings are conducted every month for detailed presentation of these scrutiny notes. ADHS FW, our Additional Director Family Welfare, is chairing that online review meetings. And in that online review meeting, officers at the block level will be attending. And after this review meeting, a detailed minutes will be prepared and circulate to the facilities. Next. This is what we are doing every month in the detailed online review meeting. We are presenting this type of PPTs. After the review meeting, minutes of the meeting is disseminated and the action plan is monitored at the meeting minutes from the data validation meeting is distributed within a week. Following the meeting to serve a reminder of the issue that were discussed. And based on selected key performance indicators, that are state-specific key performance indicators, every month we prepare fact sheets. These are the models of fact sheets we prepare every month. And these fact sheets, we send it to our minister's office and also to our principal secretary, our DHS and our mission director, and also to all the nodal officers for a ready reference. These are some examples of our fact sheets. And another one activity we do is the district ranking based on the state specific selected key performance indicators and weightage. We used to prepare a composite index and we rank the whole districts every month. And that ranking is presented in the SMO conference every month. That's very, as far as our experience, that's very much useful for improving the data quality. Thank you.
Thank you, ma'am. मैम आपका कर पीपीटी Now PRC team will present the DH ranking and data verification slides.
Hi, good evening all. Hi, ma'am. What's the background of this activity that you on the PRCs are doing? What should I do now? No, ma'am. Actually, this was prepared by a second man. Yeah, that's true. Yeah. That the background of this. So I'll just start that session. Good evening, everyone. So this session, after the all the technical sessions that we've held, all of you might be aware, the state people and the PRC teams also, that the DH ranking exercise, which is being done by Niti Aayog, is based on the HMIS data. And along with that, the HMIS data, which is used in that ranking exercise, is physically verified by a third party, which is appointed by Niti Aayog itself. So, as a pre-exercise to that exercise or a routine exercise to improve data quality, because we've been working on HMIS data, desk job, data quality, we've been doing it since last more than 10 years. So now our team has also advanced, and similarly PRC team has also gone to the next level of physical verification of data, whatever is reported on the HMIS portal. So you might be knowing that our teams also go and we also keep on giving you the feedback. And this particular presentation is based on the visit. This is a joint presentation on all the visits that were made by PRCs to the states for DH data physical verification. So the observations that they are presenting are very important because this was done once. But Niti Aayog is going to do this exercise regularly, and apart from Niti Aayog, our data quality is very important for us also. So all these insights, maybe they are pointing one observation for a particular state, but we found that those things apply to other states also. So everyone has to go back and work on these lines. We have to rectify all these things. And so that next time when the PR, because this time the PRC teams have been given that additional task that if they revisit a DH, which they visited last year, so they have to give a comparative data also, okay, whatever problems were encountered last year, have they been rectified after the recommendations given by them? So ma'am would be presenting that. I just wanted to give a pre to that.
Thank you. So this one is the data DH, while some of the PRCs when visiting the health facilities. So when they have visited the health facilities, they found some problems or some issues while going through the HMIS. And this was the thing, and this was prepared by our ma'am. Yesterday only we have finished night only we have finished the work. So the first thing we have, I will present you the type of errors and the cause of errors. And the first thing is data entry error we have found in the HMIS. And the main cause of data entry error is majority of the data entry officers or data entry persons, they are unaware of the concepts. And due to carelessness also they make such mistakes in the facilities. And the other one is data consolidation errors. And the main cause of data consolidation is failure to include data from the different departments in each facilities. And the next one is calculation errors. And the main cause of calculation errors is lack of proper register maintenance in each facilities. This was found by the PRC team in each PRCs while visiting the facilities. And the other thing is lack of conceptual clarity. And the cause of errors is failure to follow data definition and lack of training. So the other file is that Word file, not this one, the Word. This should be minimized, okay? This should come next. So in the DH ranking, we have found these all things, that some data capture issues in the HMIS in different states. What we found was in the data element, live birth for male and female, the actual definition, it is written there. All of you know, and once again, I am explaining it. Total number of male live births during the reporting month and total number of female live births during the report month. It is the actual definition of what is live birth male and live birth female. But the thing is, the errors observed in Karnataka was data mismatch, and the cause of error is twin birth was counted as single birth. So like this, errors are happening in some of the facilities, not only in Karnataka, in other states also. So the next one is number of newborns breastfed within 1 hour of birth, and out of the total number of live births, newborns who were breastfed within 1 hour of delivery during the reporting month has to be reported. But in Karnataka, the HMIS and register data matches, but data capture was found to be wrong. And Madhya Pradesh also wrong data reporting. And the cause of error is for C-section deliveries, this data item is not captured and recorded in specific register, while labor room register mentions the proportion of newborn breastfed within 1 hour of birth. And also newborns admitted in SNCUs, C-section babies are omitted. So the items need to be clarified is that require clarification is child care registry is not maintained usually, and such information is not recorded in the SNCU register. Next is allopathic. Allopathic outpatient attendance. So actual definition is total number of new and old outpatients attended at the DH during the reporting month. So the OPD should include immunization and routine ANC cases of DH. But in Kerala, we found the errors as HMIS figure is less than the actual number of total allopathic, total outpatient data in the register. And in the HMIS figure matches the total allopathic OPD in the register, but casualty OPD is also counted. So the emergency OPD was not counted while uploading the HMIS. So following state instructions, the total number of emergency OPD was deleted from the total allopathic attendance. So DH was not consulted. So the people were entering the outpatient, emergency outpatient attendance also, but the state just deleted it, and they hadn't informed about this correction they have done to the district also. So following wrong definition of variable also. So some DH are, so we need clarification on some DH are adding and some are not adding. So the data definition made to be modified to include the emergency OPD. The other thing is, the next one is Ayush outpatient attendance. The total number of new and old, the data definition is the total number of new and old outpatient Ayush attended at the DH during the reporting month. But in Kerala, the Ayush wing functions in the same compound of the hospital, and the utilization of services is also very high. But the OPD is not reported because Ayush doctor is under ISM. So in Kerala, lack of clarity as Ayush is not mainstreamed in Kerala. So we need clarification on should the Ayush OPD should also be reported in such cases, or should Ayush medical officer should be included in the human resources. No, ma'am. In Kerala, this Ayush doctors come under ISM. So whether they also, the people who are utilizing services from allopathy, they go for Ayush services also. So yeah, they are not, they are in the same DH only, but they are appointed not by the DMO or NHM. So we can report. Okay, so in the human resources also we can enter that. She's there. Okay. What is the actual status regarding Ayush medical officer?
Yeah. Because ma'am, in the Ayush facility, there is no data entry operator. In the same DH, ma'am, but the controlling officers are different. There is some. Yeah, we have already given the direction. But there is some issue in.
So the Ayush details also we can enter, no, ma'am? Okay. So the next one is, okay. Shall I continue, ma'am? Next one is operation major. So this operation major include general and spinal anesthesia, and it is written in the data definition that it should include C-section delivery. But in Tamil Nadu, it was seen that gynec procedures, not only C-section delivery, but the gynec procedures which are major operations other than C-section deliveries are also not counted. And in Madhya Pradesh also data error is there, and lack of clarity in the concept among the staff nurses, and cataract operations were also included in this data element because there is no separate variable in HMIS to report ophthalmic surgeries. But in the new HMIS format, new format provides more clarity on these things. So now regarding operation minor, the total number of minor surgeries excluding obsgyn and ophthalmology, but this is a measure of minor surgical care. But in Kerala, the main thing we found was the minor procedures in the casualty, especially orthopedic cases were also included. So while coming to casualty, these minor surgeries can be included, no ma'am? Okay, we can report. So in this we found that it is due to lack of clarity in the concept, and we can include, no ma'am? So The next one is number of post-operative surgical site infection and the number of post-operative surgical site infections attended by the facility in the reporting month. And this would include all infection cases attended by the reporting facility, even if the surgery was performed in any other facility. But in Delhi, no standardized format of recording the surgical site infection. And in Kerala, also HMIS and register data mismatches. So the cause of error is surgical site infection occurring in only surgical ward are included, and OPD cases of surgical site infections are not used. I mean, it is missed. So the data definition strictly is not followed. The data definition says that this would include all infection cases attended by the reporting facility, even if the surgery was performed at any other facility, but it is not included. Yeah.
Kerala can tell other states also. May please tell, ma'am, why is this not reported? Any idea?
Surgeries conducted in the facility. If we included all the surgery site infections reported in OP, the rate will be high, madam. So that is the reason they are avoiding. Then but no. The rate of surgical site infection will affect the sanitary conditions of the hospital. Rate is high, then there will be complaint on the hospital. So if we include
Yes,
all OP surgery site infections of other hospitals site infections also, then this hospital rate will be high. Maybe, but they are attending. But here rate will affect the reporting process. Sir?
The next one is regarding the inpatient head count at midnight. Yes.
Actually, we have also visited a lot of district hospitals in many of the states, except for Bihar. I have not seen even. I have only seen it in Bihar that they are at least recording it on the registers, even though they are not reporting it at HMIS. But in other states, I have not even seen the registers available for reporting this indicator.
I would like to intervene here, sir, that they have, some of them informed us that they have been asked to underplay the surgical site infections because the scores get affected, especially the Lakshya scores and some other scores, district ranking scores get affected. Therefore, they underplay the surgical site infections. In Madhya Pradesh, some of the districts which I have visited,
Yeah. Yeah. So it can be. It's a difficult data element. So then, okay, ma'am. Next is inpatient head count at midnight. The data definition is total number of inpatients admitted in the DH who are present at midnight or at 6 a.m. So many of the states shows the data mismatch. Maybe the main thing is lack of clarity in definition among the staff. Usually in many of the health facilities, the staff are not aware about what is inpatient head count.
occupancy rate. This item is very clear. मैं ही कम से कम I have told it 100,000 times. If you go to a hospital, let us go to a hospital tomorrow. Every staff nurse, the nursing superintendents, they know this thing that every night a head count is done in every ward because they have to prepare for next day things. So every night there is a head count done. So all those head counts done every day have to be added for the entire month and reported here. This divided by the number of bed days is the only way of getting the bed occupancy rate, which is a very important parameter showing the efficiency of the hospital, how is it functioning. So if the states are saying we don't know, then it is the responsibility of all the PRCs. So next time whenever we go there, we need to educate them कि जो आपके वार्ड में रात को हर एक स्टाफ नर्स करती है, आप जब भी जाएंगे ना किसी वार्ड में जाके स्टाफ नर्स से पूछिएगा, गो एंड आस्क देम कि डू यू डू अ मिडनाइट सेंसस, मिडनाइट हेड काउंट, ऐसा कुछ ना कुछ आसपास का शब्द वो बोलेगी जो वो करती होगी, एंड दे मेंटेन इट. उनके रजिस्टर में लिखा होता है कि मेरे पास रात को इतना पेशेंट था, जो सुबह आके शाम को जा रहा है वो हमारे पास डे केयर आ गया है अब नए फॉर्मेट में, दे हैव टू बी रिपोर्टेड इन डे केयर. बट जो पेशेंट 24 घंटे जो रात को 12 बजे मेरे पास डीएच में था, आपके कभी कोई रिलेटिव भी जब एडमिट अगर कभी हॉस्पिटल जाना होगा तो एवरीवन नोज दैट जब इवनिंग राउंड पे डॉक्टर आते हैं तो वो डिस्चार्ज के लिए बोल जाते हैं, और अगर जो रात को रुके होते हैं वो मॉर्निंग में जब राउंड पे आते हैं डिस्चार्ज करना होता है तो वो कर देते हैं. तो जो रात को रुक रहा है, so whosoever is staying in the hospital at night at 12 o'clock is to be counted every day, added for the month, gives us the inpatient head count at midnight for that month. Is it? I hope it's clear to everyone. So are all the states who are present here reporting it?
So next one is stock out rate of essential drugs. So the actual definition is average availability percentage of EDL at the respective DH for each calendar month. Most of the states report the problem in this data element. Actually, the pharmacists, pardon me? Okay. Yeah. So it is not availability, no? Non-availability. Okay, ma'am. Thank you. Next one is regarding blood units issued on replacement. That also the data definition is total number of blood units issued on replacement donation during the reporting month. So that is the guidelines, it is written as number of blood units collected with replacement donation, means that a patient's attender is being asked to give blood units for getting blood from the blood bank. So in Kerala, so many voluntary donors are there. So they are at the DH. So other than patient attender. So there is a confusion on the concept. So whether that should also be included. We need clarification. Yeah.
One of your relatives or someone known come in, and that is a negative indicator. So again a negative. The more number of blood unit or replacement you are giving, it is a negative indicator because we always promote voluntary blood. But if they have some voluntary donors who are always there to donate, then it will be counted here. This is only patient relative. If we go and tell your patient is not well, we need to get blood from you. So you call your relatives or they come and donate in you or bank. So that is only blood unit issued on replacement. Otherwise, a voluntary donation is a voluntary donation. Even if it is not blood donation, or it is like.
So ma'am, that blood units donated by the volunteers should also be counted? No. Okay.
When you are demanding it.
Okay.
Everyone is reporting. Have a mixed batch here, some inputs from PRC, but the states are what they are doing.
So the next one is total number of blood units issued in a month. That also the total number of blood units issued in the reporting month is the definition. So in Tamil Nadu we found that. Okay. Okay. The other one is regarding number of lab tests done. So the total number of lab tests conducted at the facility during the reporting month. In Kerala, the thyroid tests counted separately and outsourced lab tests are not included. So HMIS figures is less than that in the register, and in Madhya Pradesh also under-reporting in HMIS. So the blood samples for some tests for patients are collected by outsourced labs, and some state has instructed to eliminate the COVID tests. So error occurred in the district level. So lab tests from all departments are not included. So we have a doubt regarding, yeah. Thyroid test only it is thyroid function test to be counted as TSH, T3, T4, free T3 and free T4, or it is counted as 1 or 5. The hospital, not in every hospital. In some hospitals we have visited. That we need to clarify. Ernakulam, I think it is in Ernakulam. For not for all the facilities we have visited right now. And also, should outsourced lab tests be included? The outsourced lab tests should also be included, no? Okay.
Clarified that even if you are doing tests through outsource, you will be reporting here. But in new format, this confusion is all over.
Yeah.
In the service delivery also, in infrastructure also, you would have seen it is all very clear now. But one thing is, one concept we have to maintain, that whatever services are being provided or as outsourced, but they will report because they are being done by them only. It is being organized by them, I'll use that word. So all the outsource, but now this confusion won't happen because we've clarified it. Most of the things, the observations that we had encountered, we've tried to incorporate them in the new formats. And still, if you feel something is left, we had asked in the morning also. Now also the forum is open. If you still feel something is left, do give us feedback. We are open for feedbacks.
So the other one is patient satisfaction score of the facility in percentage. The actual definition is mean of individual patient feedback scores expressed as percentage. But in Delhi, this calculated, but data element is left blank, and in Gujarat also data is not captured. So this is due to the cause of error is due to non-availability of a quality manager and lack of awareness regarding these indicators. Mera Aspatal portal was reportedly not functional, and the item we need to clarify is, can facility level patient satisfaction score be uploaded?
Application based on that, data has to be reported. Similarly, in stock out also, it was DBDMS based, whatever stock out rate, that has to be reported here.
Okay.
DBDMS means DBDMS or equivalent state level. So similarly here also in Mera Aspatal application is functional. Then their patient has.
Many of the facilities they have blanked it. It's not there.
Because idea was, in fact, in the beginning only, that these all applications should come, these all applications should work, and then information should come from here only.
Now this word file is over.
In the state of Goa, we had this Mera Aspatal implemented in 2 district hospitals. But recently means last year we had shifted to a new HIS system. But now they are not incorporating this new, they are saying that they cannot be incorporated. This is what.
The earlier one, the PowerPoint presentations.
Yeah, means that new HIS, they have to incorporate into that, no? So Mera Aspatal, their team, they have told us that it is not possible for them to include these new hospitals. Yeah, it is going on for a long time, madam.
So the other next one is regarding the infrastructure format. First is human resources. So the first thing is lack of clarity in data uploading on HR. So the should MO, medical officers deputed to other hospitals but drawing salary from the DH be included in the HMIS. So maybe in one facility, 4 MOs will be there, but 2 are working there and 2 are not included. So the calculation of OPD per doctor per day is an issue in such cases. Salary? Okay. Yeah. Sir. This
Working more than 15. Put into in-person the facility itself. He can draw salary from anywhere because their services is giving in the facility only. Yes. More than 15 days means we have to put the in-person at the same facility. Yes. 15 days, more than 15 days. Yes. Yes. In position. Yes.
I'm in Maharashtra. What happened? Like we visited the person who is entering the data. She's facing a lot of because now we have the regular contractual and outsourcing. 3 columns are there. But in Maharashtra, some positions are appointed by Jilla Parishad on bonded basis. In that case, they are confused where to enter this data. So contractual or outsourcing as a contractual. But that it is bonded. That contract is from Jilla Parishad, not from the this. So they are not very clear with that, karke. So that is an issue. And regarding yes, but that local Jilla Parishad, that Maharashtra, this is the main issue. Right now, she is facing because I recently visited District Hospital Pune. She is clueless. So I told I will first ask here what is the right method, and then bonded labor. And regarding this Mera Hospital, man, that right now I have seen the registers and like Likert scale, they have that average scores and this. So I interacted with some of the patients also. So informally I visited. So they देखो आप हमको इनके सामने ही एवरेज देने को बोलते हैं तो गुड ही देंगे ना. So, yeah. So that's what I feedback. I thought to tell you because District Hospital Pune, this was this. Yes, yeah. No, the patients are telling us like this, and there should be some, because district hospital they are getting, but when they are calculating the percentage, that is not right. They are just see, average they are taking, but how much is the percentage, that there is some problem, because they are not taking the total number of patients and that, because when we are evaluating, they are giving in percent, no, like that. So that needs some training is what I think, ma'am. That's what. Thank you for.
So the other thing,
मैम इसी में मैडम ने जो बताया उसी में आगे जोड़ना चाह रहा था। झारखंड में एक डिस्ट्रिक्ट अस्पताल है धनबाद का मैडम, तो वहाँ पे तो थर्ड पार्टी, जैसे कि वहाँ पे डिस्ट्रिक्ट मिनरल्स एरिया डेवलपमेंट अथॉरिटी करके है। मैम वहाँ थर्ड पार्टी डिस्ट्रिक्ट मिनरल डेवलपमेंट अथॉरिटी करके है, और पूरा पूरा वो डिस्ट्रिक्ट अस्पताल ही चला रहा है। लगभग 80% HR उसके हैं, जिसके द्वारा हॉस्पिटल रन हो रहा है। तो फिर वही HR वाला आता है कि वो HMIS में किसको डाले। पर्टिकुलर धनबाद डिस्ट्रिक्ट है जहां तक मुझे याद आ रहा है जी।
Working on that because so it definitely. Yes. So the other thing is already clarified. HMIS. Okay.
Second point, ma'am. So since the new system has been launched, that is since 2020, we have been, this is, if someone has some doubt, they can.
Can the HMIS infrastructure formats be revised as and when there is a change in HR? So in the first point, no? Yeah. Yes, yes, yes. Yeah, no. Updation. No, no, no. Not new post. Yeah, yeah.
Monday. All those regions. But that. What we so this is
Okay, ma'am. The third one is okay. That's already clarified. Regarding the population, is it the projected district population that has to be given in HMIS for DH? In case of 2 DH or GH, what should be the population? Some DH are uploading only the area they serve. So. Okay. Yeah. So regarding the bed strength also, some of the DH that have increased their bed strength and crossed the respective bed strength category of either 201 to 300 or 300 and above. But in HMIS 2, it has not been changed and sanctioned HR also, the पहले वाला जैसा ही थे. 300. So our ma'am has written some of the suggestions to eliminate the errors. So these are the suggestions: repeated trainings on the concepts and data definition to the staff, to enhance monitoring by the block, district and state level officers, frequent and random verification of data in HMIS with registers by the medical officer or HMIS in charge at the hospital. Then proper distribution of HMIS formats and supply of registers for maintaining hard copies of data uploaded and register maintenance. And state or district team need to inform the changes made in HMIS to the respective health facility as and when changes are effected following communications from state to the districts. So the new data, new HMIS data format 2023-24 is only some health facilities have started uploading data. This is the new status as well. No status. Last week only we have visited. Yeah, but only. Yes. But nobody has started entering. Only some. Not nobody. Some facilities have started. Yeah. Yeah, we have visited Ernakulam district, Tirupur, Tamil Nadu, then Kanyakumari. Kanyakumari has already started entering. All are maintaining hard copies. Hard copies maintain करते. Okay, only for April. Yeah. Okay, ma'am. Okay, ma'am. Now the staff are not aware of the changes made in the new format. These are the things we have seen while visiting the facility. That's why the staff are awaiting training for new formats, and some of the facilities that have started uploading for the month of April 2023 are maintaining hard copies of the filled formats also. And districts need to ensure availability of proper printed formats. And since outreach data are being captured in the new format, staff need to be trained early in recording the outreach activities as per the HMIS format in advance. Then maintenance of registers need to be based on new format as additional data items are included. Trainings need to specifically focus on the changes to be made in the register maintenance. Disrupted network facilities to upload the data is reported from Assam. Thank you.
Thank you, PRC team.
Quality inauguration.
So the speakers.
A very pleasant good evening, ladies and gentlemen. Indeed, some days bring with them loads of laughter, happiness, and joy. Also, some days bring along with them shades of gloom. But today, my friends, is a gift by itself. It brought all of us here together. We appreciate and we extremely admire your efforts to be here even within the harsh weather conditions. It is very true that the weather today was not very kind with us. Welcome to the jewel of the East Coast. I am Harshita Devaguptapu, and we are very delighted to receive all of you here in Visakhapatnam at the joint workshop of the Health Management and Information Systems and also the Population Research Centers, organized by the Ministry of Health and Family Welfare, Government of India, New Delhi, in association with the Population Research Center, Andhra University, Visakhapatnam, Andhra Pradesh. Ladies and gentlemen, on this note, I would like to call for the following dignitaries to grace us with their glorious presence on the head table. The president of the workshop, Professor B. Munnuswamy Garu, Honorary Director, Population Research Center, Andhra University. Our honorable guest, Professor V. Krishnamohan Garu, Registrar, Andhra University. Please, sir. Also, ladies and gentlemen, let us welcome our honorable guest, Professor K. Srinivasa Rao Garu, Principal, Andhra University, College of Science and Technology. Please, sir. We also heartily welcome Ms. Preeti Tiwari Garu, Assistant Director, Ministry of Health and Family Welfare, Government of India. We cordially welcome Shri Kumar Sundaram Garu, Director, Ministry of Health and Family Welfare, Government of India. And our chief guest for this workshop, Ms. Anjali Rawat, Deputy Director General, Ministry of Health and Family Welfare, Government of India. Ladies and gentlemen, I now welcome our chief guest and our other distinguished dignitaries to join us in the traditional lighting of the oil lamp. Within the sweet melody of a prayer song. As it is customary in this part of the world, we commence any auspicious occasion with divine blessings. And that light is a testimony to ushering in positive energy and motivation for our occasion.
गणनायकाय गणदैवताय गणाध्यक्षाय
Ms. Anjali Rawat, Director, Ministry of Health and Family Welfare, Government of India. Joined by our registrars, Professor V. Krishnamohan Rao Garu, Registrar, Andhra University.
गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Joined by Ms. Preeti Tiwari, Assistant Director, Ministry of Health and Family Welfare, Government of India. Joined by Professor K. Srinivas Rao Garu, Principal, College of Science and Technology, Andhra University.
विक्रमाय तुय्य प्रवराय गुरवे गुणगुरवे गुरुधर्म सताराध्याय गुरुपुत्र परितात्रे
Knowledge is power. It controls access to opportunity and advancement. These are the words quoted by Peter Drucker. I now welcome the president of our workshop, Professor B. Muniswamy Garu, for his opening remarks.
Today's function, chief guest, Anjali Rawat, Director General, Deputy Director General, Ministry of Health and Family Welfare, our dynamic registrar, Professor V. Krishnamohan Garu, Registrar of Andhra University, Vishakhapatnam, Andhra University College of Science and Technology, Principal, Professor K. Srinivasarao Garu, Director, Preeti Madam, Kumar Sundaram Garu, Kumar Sir, so Preeti Madam, dignitaries of the dais, HMIS and PRC participants, press and media. A very good evening to one and all. So I am happy to host 2 days workshop of HMIS and PRCs. First of all, I appreciate Ministry of Health and Family Welfare team. They taken very interest to host 2 days workshop in Andhra University Population Research Center, right? So actually they taken 1 day to come to Vishakhapatnam. Okay, a lot of trouble. But even though Madam is taken a lot of time and dedication, right, to conduct a smooth functioning of program. So even though she is at airport, so she is suggesting every minute, right? So she given a very impressive to conduct this smooth. So I thank Anjali ma'am and your team for conducting a smooth functioning of this workshop. Thank you, ma'am. Thank you. So always our population research center is established in the year 1977 with the headship of Professor T.V. Avadar Garu. He served as head Department of Statistics and principal College of Science and Technology. So our Andhra University established in the year 1926. So 97 years old university. So I feel very proud to smooth conduct of Population Research Center in the Andhra University. So ministry is 100% giving financial support. So our Andhra University administration, our Vice Chancellor, Professor PVGD Prasad Reddy, and our Registrar, Professor V. Krishnamohan Garu, they are giving 100% support. Whatever we ask, so immediately they are agree to do any events, any programs we conduct. So I also thank to our ministry and as well as Andhra University administrations. So our principal is also, so tomorrow speaker, Professor K. Srinivasarao Garu, he is our statistics department, senior professor. Right? He is also always giving some suggestions to conduct such type of programs. So I thank you, sir, Srinivasarao Garu. So our Andhra University, so you see our former president of India, Dr. Sarvepalli Radhakrishna, served as a Vice Chancellor of Andhra University. So, Nobel laureate, Sir C.V. Raman, he is also our alumni of Andhra University. So, he served in the physics department, so and also mathematics and statistics legend. Recently, he taken equivalent to the Nobel Prize award, Professor C.R. Rao. He studied in the Andhra University. He is also our proud alumni of Andhra University. So this is just a brief history of Andhra University. So our population research center, as of now, we conducted 199 research reports submitted, 16 research studies conducted. So 13 seminars, conference, workshops are conducted, and also we are giving some consultancy works. So in the year 2021, we estimated population projections of Amaravati. Amaravati Development Authority. So we given to the ministry, to the Andhra Pradesh population estimation projections. And also we conducted some major projects of UNICEF. And also our population research center involved in the HMIS, DLHS, right? So all the surveys is also we are involving. So the first day, today we are conducting the program schedule is only for HMIS people. So second day is we are going to conduct data analysis by using statistical packages, hands-on experience. First of all, I thank to the Ministry of Health and Family Welfare. They sanctioned SPSS package licensed version. So we have purchased 10 licensed version for analyzing the data. Ministry is sanctioned. So thank you, ma'am, for sanctioning this. Okay, thank you very much. So I hope the first day we have conducted successfully, right? So thank you very much for giving this opportunity. Thank you, sir.
Thank you very much, sir. We heartily welcome the heads and representatives from 18 population research centers, HMIS delegates from 10 states all over India to the Koinur of India, Andhra Pradesh. On this note, may I now welcome the principal of College of Science and Technology, Professor K. Srinivas Rao Garu, to share wise words with us.
Respected Madam Anjali Rawat, the Deputy Director General of Statistics, MOHFS, Government of India. Our very, very dynamic, visionary registrar of Andhra University, Professor Krishna Mohan Garu. Another guest of honor, Sri Kumar Sundaram, Director Statistics, MOHF, Government of India. And Assistant Director Statistics, Preeti Tiwari, Ministry of Health and Family Welfare, Government of India. Delegates of this workshop, very good evening to you all. It's a pleasure for me to associate with this workshop. This type of workshops are very much needed nowadays to transfer the knowledge, to share the thought processes, to have innovative thinking in every direction. And definitely the health management and information system associated with the population research centers, having a joint workshop, that is a very, very nice initiative taken by the ministry. I thank and congratulate the authorities who have taken this initiative. Particularly, I thank Ms. Anjali Rawat to sanctioning this workshop, particularly to our PRC of Andhra University. And we are very happy to organize this. And in fact, We know that every one of us, all the delegates who are attending this workshop are very much involved with handling the data and data management and data-driven approaches for right decisions at right times. But very important thing is the recent advances, as well as the way how we are dealing things and what are the actual insights that are required to be taken care. And this type of things are very much important. I hope this workshop will definitely fulfill that objective in which the ministry has taken up this initiative. And coming to our Andhra University, Andhra University is one of the very, very well-established primary institutions. Even though it is a state university, it is no way less than any other primary institution in the country. Recently in the NRF ranking, our Andhra University got 15th rank in Innovations University. The first 10 are from IITs and IIMs. And ours is the first state university, in fact, to get that innovative and initiatives. I thank our visionary Vice Chancellor and dynamic registrar for taking several initiatives for the last 4 years in Andhra University to bring a revolutionary change in not only in the Andhra University education system, but the state of Andhra Pradesh, the education system of higher education institutions. And we have 16 research centers. PRC is one of the best research centers we have because it is taking up the projects which was assigned by the Ministry of Family Wealth and Family Health and Family Welfare of Government of India, but also the projects that were assigned that were very much important for the societal development and community development. So the Population Research Center, in collaboration with the Department of Statistics, we are doing a lot of projects which have significance with the societal development. And also our Andhra University, with the help of Unnat Bharat Abhiyan, we are taking up several of the initiatives to bring the awareness and also propagate the right methodologies for health and family development. So in several ways, this Population Research Center is contributing not only just for the academic advancement, but also for the societal development. I congratulate Professor Muniswamy and his team for doing a very nice work. And the Population Research Center is associated with our college. I am proud that the PRC is with the Department of Statistics, initiated by Professor Avadhani in 1971, if I am not wrong, 77. At that time, it was the Demographic Research Center. And with these few remarks, I once again thank Anjali Rawat and her team for taking all the pains to come over to Visakhapatnam, even though the weather is not very cooperative, and also giving an opportunity for our Andhra University to conduct this workshop. I have Center of Excellence in Health Management and Population Dynamics. Thank you, madam, for all your initiatives. Visakhapatnam is one of the wonderful cities, I say. It is the city used to call. And there are several places to visit. Even though the weather is not very cooperative, I hope by tomorrow it will be very, very cooperative. Now it is, the clouds have gone. So you can visit Visakhapatnam. And I hope Muniswamy will arrange a small pleasure trip to you also, along with this academic knowledge transfer. Thank you. Thank you all.
We are very grateful for your notable remarks. Professor V. Krishna.
Great evening.
Our honorable guest, Registrar, Andhra University, Professor V. Krishna Garu, share a few words with us.
I am so happy to be here amidst learned personalities on the dais, off the dais, and I'm so glad that the joint workshop of HMIS and PRCs is happening today with the guidance and also involvement from the chief guest sitting on the dais, as Anjali Rawat, Deputy Director General, Ministry of Health and Family Welfare, Government of India, and also on the dais, Shri Kumar Sundaram, Director Statistics, Ministry of Health, again Family Welfare, Government of India, and Mrs. Preeti Tiwari, Assistant Director Statistics, and our beloved Principal, Professor K. Srinivasa Rao, a renowned statistician known in the country, and PRC Director, Professor Muniswamy, who has given his opening remarks. I am so glad and very privileged to stand before all of you. That workshops normally organized to improve any existing system and invent new methods and ways how the principles can be changed, processes can be evolved, so that along with the current trends, whatever systems that we use, whatever policy framework that we develop, need to reflect to the contemporary issues in order to face the challenges ahead. I believe through this workshop, you are all going to provide necessary inputs. And when I came here, I was just listening somebody's presentation that a revised format was introduced and they need training. These days, you can take help of technology, step-by-step procedure, probably small video clips can also be given, and any doubts can be clarified. And further improvement over the existing system can always be suggested in any workshop of this nature. I believe with the active involvement of the concerned staff, especially from PRC, who are there to use the systems. Population and health, both are equally important topics. And day before yesterday, somebody was asking me to write an article on population, whether the growth of population is a bliss or bane. Gone are those days of considering as a bliss or a bane. Population, definitely very, very valuable human resource. Earlier in India, how do we control population? Used to be a major concern. Now, how do we utilize productively so that the country's growth prospects always possible in the context of globalization? If other countries are exporting the best products, we are exporting the best brains from India to various other countries initially. Through these best brains, the experience transfer, which is very, very valuable, a name is given to this as a reverse migration in management. And this reverse migration is a welcome step in India. The younger population who are going abroad, after gaining experience, vast experience, and working in premier, internationally reputed institutions in coveted positions, when they come back, their experience is valuable here. When they start new startups, ventures,
definitely it is going to become added to the economy. They create employment opportunities that is today the Make in India or Narendra Modi ji concept of Atma Nirbhar concept is also becoming a reality. Unless we change according to the conditions, situations, ready with our own plans and strategies, we cannot cope up with the change. Change is always challenging. Change need to be visualized. And unless we make our preparation to accept challenges of change, we will be facing impediments. This could be the reason why all of you know how important health of population. Unless the population in a country are healthy, we cannot make country wealthy. Health is wealth, as many people would say, is true. Now there is growing consciousness in the country. How do we improve our health conditions? Policy makers in population area as well as health management, information systems are very vital. So how do we design information systems so that the information gathered, maintained, updated or validated is going to be helpful in drafting good policy framework? Is the reason why Government of India is spending so much on statistics collection, preservation, and today, these days, advanced tools in data management. All of data science today grew beyond our imagination. And if you use data mining techniques, I think connecting unconnected things earlier with the help of software packages available, new dimensions, new directions, new policy framework in order to prepare a good policy framework is possible if the inputs provided by all of us in the form of information and data is reliable. That could be the reason why I think government is spending so much budget, resources, and the people who are involved here through all these population centers and also health management information system managed by health professionals is going to become a very important input in the country in knowing the requirements of maintaining good health of the citizens, of the population in India. So a sick person can never be productive. A sick person is always a parasite on the society, as we understand. So how do we, cure sick people is not the issue here. How do we prevent diseases? Prevention is always better than cure. So through these health management information systems, we are going to forecast in advance the health condition, what it is going to be in the near future. As such, we can prevent any hazards in the domain of health management. How we are going to make use of the information systems for policy making, for implementation, for review and control is going to be a matter of great concern to the bureaucrats and government. So towards this direction, taking up the joint workshop, I believe, is very helpful, useful, timely, contemporary, and productive in addressing the issues and challenges in the field of both population and health management of the citizens of the country. Based on that, which is going to become basis for allocation of resources for health management, resources for prevention of diseases, and making everybody healthy and free from any ailments in this country is going to provide a bright future in India. As India is a progressive country on economic front and social front, if you want an equal balance and people should be disease free, people should be happy at the end. That is how happiness index is measure of progress of any society. Sick people can never be happy. So how do we make everybody is happy is going to be a great concern to the health department, to the bureaucrats and policy makers. So I take this opportunity and profusely thank the organizers for giving me this opportunity to share some of my thoughts. And also I am very thankful to the chief guest, Ms. Anjali Rawat, Deputy Director General and Ministry of Health and Family Welfare, Government of India, for giving us an opportunity to organize this workshop jointly by PRC at Andhra University. It is always discharging their duties. They call the sincere. We are committed for the cause of the nation, and the objectives with which this PRC is sanctioned, we always understood. And recently, I was there when digital was also inaugurated at Andhra University, and it is also, live information provided to citizens of Visakhapatnam and people who are interested in knowing the changing population structure in India, right? And in the end, I wanted to wish the rest of the deliberations definitely going to yield, required information. So in turn, these channels got exposed to this two-day workshop will go a long way in building foolproof health management systems for product based.
Thankful for those illicit words of yours, sir. I've started at my home to reach this venue. I heard some of our respected delegates talk among themselves, describing us to be very welcoming. And it is very true indeed. I think in the same spirit, with the same warmth, we now welcome the Honorable Chief Guest of today's program, Ms. Anjali Rawat Garu, Deputy Director General, to please share few words with us.
Good evening, everyone. Professor V. Krishna Mohan, Registrar, Andhra University. Professor K. Srinivasa Rao, Principal, College of Science and Technology, Andhra University. Professor B. Muniswamy, Honorary Director, PRC, Andhra University. Director Kumar Sundaram from the Ministry. Preeti Tiwari, Assistant Director from the Ministry. All the participants from the 8 states, I hope they are here with us, and 18 population research centers. I welcome you all for this 2-day workshop. We've already finished the first day. My welcome is a little late, but I'm so sorry. Got stuck up in some unavoidable circumstances. Nothing was in my hands, so I'm very sorry I'm late for this program. So basically, I would like to first thank PRC Visakhapatnam to coming to be able to hold this workshop. We just suggested them once, and they were very forthcoming in taking up this event. And this is the first event of its kind where we have tried to collaborate the PRC with the state NHM. And now, why was this required was, see, there's a mandate that we need to strengthen our population research centers. Population, as Sir has already mentioned, is an upcoming subject. We are exceeding the population of many other countries. So it's very upcoming. It has always been very upcoming subject. So now, population research centers is very much under the eye of Niti Aayog, and after what I have been always telling that Niti Aayog has done an evaluation of our PRCs, and after the evaluation, there are a lot of recommendations which came up, and one of the recommendation is that we need to strengthen our PRCs. Now, over the years, just to give you some statistics, the PRCs have already been involved in a lot of NHM PIP work. They had also doing district hospitals data verification, physical data verification. So around 403 districts were covered in 22-23 by our population research centers, and almost 50 to 60% these district hospitals have been visited. So this collaborative exercise was to orient the PRCs and the NHM together on the new formats, plus to bring that collaboration together at one platform. So this is a platform where the PRCs are able to talk to the NHM, and NHM gets aware of these research centers which are there. These research centers are also open to take up any research activity for the state, so which they are already doing. But then few states we still feel they can utilize this population research centers. We have expertise, we have wonderful professors of great caliber sitting in these PRCs. They can be utilized for conducting any kind of evaluation or any kind of research for your particular scheme or projects of the state. So this was our basic concept when we started this workshop, when we thought of holding a joint workshop. This is the concept which we had in mind, and it was appreciated by our secretary, sir, and he gave us a green signal for conducting this workshop. And we thank PRC Vishakhapatnam to come forward in holding this. So to have a view of what we have done throughout the day, we have, as you know, that we have already launched the new formats. It's in the field. People have started collecting the data. I know still they're collecting in the physical records because we recently gave the data entry module, but now the data entry module is there in the field. The only thing which we are listening since morning is that we need to conduct trainings. Yes, training is the only measure by which these formats can be brought down to each facility level. So I would request the states to please continue with the exercise of conducting trainings, which you have been doing. So it will take us another 6 months to settle down on these formats, but it should be regular exercise. So please conduct even at the district level, go at the block level. If you require us to be connected, as sir has already told that COVID has taught us many things, we can be connected anywhere virtually. But yes, physical meetings are important. So go in the field, mobilize your staff. You should yourself be very clear on the data definitions. If there is any doubt, please, we have consultants available in the ministry. They are attached to your state. Come forward, come and ask us what are the difficulties in those data definitions, because still there are many new data definitions which you need to know yourself. And then to take them down below is another major task. So that has to be done. Unless you do regular trainings in capacity holding, we'll not be able to achieve this mandate. We have completed, we have achieved a completion status. We are 100% complete when we speak in terms of reporting in the HMIS portal. But out of this 100%, what is the quality of data we are getting? So PRC has just now given you a presentation. The last session which I kept for myself, for my team here, was the data quality. So the last session will be data quality. You yourself will see that even after so many trainings over the years, there are few data elements which we are not yet clear upon. So 2008 se jo chal raha hai, that is also not clear to us. And now I'm bringing so many new modules and so many new data elements. So an extra initiative has to come from the state. Please understand the data definitions. It is very important. Unless you properly report the data, we'll not be able to utilize the data for any kind of policy formulations. And we are very much aware that HMIS data is a source of district hospital ranking, state health index. It has become a source of ADP and ABP, aspirational district monitoring and aspirational block monitoring. So, and even at the Gram Panchayat level now, the Panchayat ministry is asking us to give us the data at the Gram Panchayat, which is not there yet in the HMIS, but we are doing that mapping exercise. So at each and every level, HMIS would become the only source of data, unless we strengthen our line listing program. So that is another activity which we have taken up. We are strengthening our RCH portal. So once that is up and running, most of the data elements into the HMIS will float from the RCH. But that is the vision. That will take us another 2 years to process and complete. So till that time, at least for the RM and CH indicators, we have to be very clear what we are reporting, because all the program divisions of the ministry are using HMIS for evaluating their schemes. And I think states must also be using that. So my only request is that we are entering the data, but we are the torchbearers, and we now need to work on the quality of data. There are two aspects. Reporting in the new formats, that is again one major task of the year, and parallelly you have to work on the quality. So when you do such kind of trainings, please conduct those trainings on both the parameters. You show the states, you show your facilities what they are reporting. We'll give you some examples, and I think over the years I've been sharing those templates with the states where you can take out the reports yourself and show what the facilities are reporting. And there might be a lot of practical problems at the field level. We understand there are data entry operators are not available. There are a lot of iteration rate. There are various what I would say state specific issues. There is a issue on the reporting period. Some states report by 25, 5th of the month. Some states report by 10. So there are many practical problems. But if we average out those practical problems, if we work on the quality, I think we'll be able to achieve most of it. Even if 80% of the data is correct, I think we have cleared those hurdles. So just to end, I would like to thank you everyone for being patient with us. I'm holding you for another half an hour. We'll try and finish one more session that is very important and interesting session. So it will give you an insight of what kind of data is actually being captured in the field and where you need to work upon. So thank you so much, and thank you PRC Vishakhapatnam for holding this workshop. Thanks a lot. Thank you.
We are very grateful for those informative words of yours, ma'am, and also those illicit suggestions that you have given all of our delegates here. May I now beseech the president of our workshop, Professor B. Munuswamy Garu, to initiate the felicitation of our guests.
Now I request the Registrar, Andhra University, and Principal, College of Science and Technology, and Honorary Director, Professor I also require the Registrar and Principal, sir, to felicitate Sri Kumar Sundaram, sir, Director Statistics, Minister of Health and Family Welfare, Government of India. Now I request the guest to felicitate Ms. Preeti Tiwari, Assistant Director, Statistics, Minister of Health and Family Welfare, Government of India. Now I request Ms. Anjali Rawat ma'am and Kumar Sundaram sir and Preeti madam, please felicitate our Registrar, Andhra University, Professor V. Krishna Mohan Garu. I also request the chief guest to felicitate our principal, Professor K. Srinivasa Rao Garu.
Now I request the dignitaries to felicitate the senior HMIS consultant, Miss Ritu Arora ma'am. Please come on to the ma'am. I also request the guest to felicitate Dr. Ugar Mohanja, sir, Senior Consultant HMIS. Yes. Fast. I also request the guest to felicitate Sri Rajiv Kumar Ahuja, Assistant Computer Programmer, Minister of Health and Family Welfare, Government of India. I also request the guest to felicitate Dr. Rakesh Sharma, Consultant HMIS. And also request the guest to felicitate Dr. Abhishek Kumar, Consultant HMIS. So is all this stuff okay. And I request all the guests to felicitate our Honorary Director, Professor B. Muniswamy, sir. Group photo. Request Srinivas, T. Srinivas and Padalu, Apparav, Prasad, please come on to the dais. I also request the research scholars and student volunteers to join. Session on the
ये क्या ये क्या देना है?
Okay. With the permission of guests, I would like to play a song, Andhra University song.
वन्दनं अभिवन्दनं वन्दनं अभिवन्दनं वन्दनं शुभवन्दनं आन्ध्रविश्वकला अखिल शास्त्र विकास मूर्तिके आन्ध्रविश्वकला अखिल शास्त्र विकास मूर्तिके वन्दनम् अभिवन्दनं शुभवन्दनं वन्दनं अभिवन्दनं शुभवन्दनं చదువు తల్లికి వేడగట్టిన మహాపురుషులు తత్వవేత్తలు చదువు తల్లికి వేడగట్టిన మహాపురుషులు తత్వవేత్తలు రట్టవంచి విశ్వలు ఎంచి పెంచిన మంచి వనమిది రట్టవంచి విష్ణుల్ ఎంచి పెంచిన మంచి వనమిది వందనం అభివందనం శుభవందనం. సరస సద్గుణ శారదాంబ పూజ సల్పిత పుణ్యమూర్తులు సరస సద్గుణ శారదాంబ పూజ సల్పిత పుణ్యమూర్తులు ఎందరో ఆచార్యులందరికీ భావందనం ఎందరో ఆచార్య అభివందనం శుభవందనం. భారతావని ఖ్యాతి చెందద మాతృభూమికి సేవ చేయద భారతావని ఖ్యాతి చెందద మాతృభూమికి సేవ చేయద వినయ భూషణ కాంతుల వరద తరలిపోయి యువతకు వినయ భూషణ కాంతుల వరద తరలిపోయిన తరుణ యువతకు వందనం అభివందనం శుభవందనం. పరమ పావన విశాలున కందరికి భావందనం ఆంధ్ర విశ్వకళా అఖిల శాస్త్ర వికాసమూర్తికి వందనం అభివందనం శుభవందనం. ఆంధ్ర విశ్వకళాతల్లికి అఖిల శాస్త్ర వికాసమూర్తికి వందనం అభివందనం శుభవందనం. అభివందనం శుభవందనం అభివందనం శుభవందనం.
I request all the participants, please take your seat. The session will continue. I request all the participants, please take your seat.
Last session. Very important session. We want to note the observations. Get them.
So we are very sorry that we got stuck in Lucknow, but fortunately we make it and we came here. So the last part of this evening and most important part of the HMIS, that is data quality. So as we all know that these are some attributes of data quality. timeliness of data. As you all over the year, we are very strict and adherence to the timeliness of data reporting. Then data entry errors. So we will show you these data entry errors, incomplete data, data consistency, and data accuracy. So these all will be shown in our following slides. So what all states we are having today. So there are some indicators. So these indicators are very crucial. So these are the current status of the percentages of these indicators for the year 2022 and 23, which is most probably like to get changed if we open the lines for correction of data. So as we can say that, see some of the outliers also, more than 100% of data, like in Puducherry, for the first four or more ANC checkups. Then we can say 7 home-based newborn care visit in case of home delivery. So percentages are more for Puducherry, Tamil Nadu, Telangana. We'll start with the Telangana. So we'll yeah. So these are only a minimum kind of examples which we have culled out from the data. But actually, if we see, there are more than these we can find out, but we is data inconsistency. So only this year in June, and then in April and July onwards, no ANC registration. Also, see in November 2022, no ANC is registered, but we have entered to 222 as first trimester registration, and also these two are also consistent figure as per the 222. So these reporting error need to be looked into for not only for this particular facility but for other also. So can we have a Telangana state team to have their views on this? Yeah. Can we have a mic for Telangana team?
Good evening, sir. Sir, there is issue with this facility. We'll convey the information, sir, because most of the facility level, the pregnant who are coming for general checkup, so they are taking into consideration as the ANC registration. So we have informed the same for all the facilities. Once again, we go through it and we'll set right these issues.
For 2 months.
Yeah, ma'am, I got it.
Is it a difficult indicator?
No, ma'am.
No. And this is what we have been collecting over years. So my only problem is that the facilities are not reporting it timely. This might come when we open the data sets again. So now all the states are requesting us to open the lines. Why will I do that now? You tell me one thing. I have opened the lines before also at many occasions, but this is what is happening. After the workshop, when we tell you that this is a problem, then you start thinking and working on it. I'm sorry, I'm being a little blunt, but you know, when we give figures to PMO or to the this parliament questions, we are lost. How can we give such kind of data? And every time we have to go back to the states to ask them. And that is done within a day's time. And that time you're able to give us data. Then during the year, during the month, you're not able to report. So this is something very not expected from any facility. So please make sure that your facilities report at least the basic KPIs, the basic ones. These are all utilized for your health index, for your DH ranking, and every other ranking process. So it's only request. We should not point out now state-wise, but I'm just mentioning it to everyone. So this is very important. Please don't miss out. Just rush through.
No.
Only this PHC has then use Mike and
rest of the year they have reported 0 figures. So is it, so we need to look into this also. Next one. DH Khammam. See, all other figures are 0. Only for 3 months the data for 180 IFA tablets and calcium tablets has been entered. So we also need to look into that whether this is correct or yeah.
It's Wednesday. That's right. Ma'am, it's a district hospital. Khammam.
Yeah.
Share this PPT.
Yeah, please.
Next.
We work on that immediately, sir.
Like similarly in UCHC. See. So this is regarding the our adolescent health indicators. So see, for rest of other months, the data is not reported. Only for 1 month, the data is complete, and for July, only one entry is there for 12 registration of girls in AFHC. So whether this CHC is giving services for adolescent health or not, that need to be looked into. Next. See, this kind of slides, we have many slides for this. See, number of girls and boys registered in AFHC. So these are same as that of the given clinical services as well as the counseling. So that cannot be technically same. So all the girls and boys which has been registered in the facility for adolescent family health clinic, so that all does not require clinical services. They might require counseling, but not clinical services. So this problem we have seen with all states. It's not only for Telangana. Then we have analyzed the C-section. As we have seen throughout the South Indian states, the C-section rate is very high. It's just a number we are showing that is this a correct figure or not? Because it is consistently high. The C-section rate in the Telangana as well as in other states of South India, this is high. Next. So this is for another DH, Peddapalli. See, for these 2 months, the data was not there. So they were consistently reporting the C-sections, and then suddenly for 2 months, data was not there. So whether this was left out by data entry operator or during that period, whether no C-section was conducted, that also need to be checked again. Then again, DH Karimnagar, consistently they are reporting the C-section high rate. Next. Khammam also. Next. King Koti. Next. Next. Yeah, this one. So in this particular branch, out of 247 deliveries, we have conducted 233 C-sections. So almost 100%, near to 100% C-sections are there. So whether it is correct or not. This is one important information which we have got. So during the whole year, we have 4 home deliveries reported in Telangana. So against those 4 home deliveries, when we taken out the indicator for 7 home-based newborn care visits, so that come to 452. So these are the district-wise breakup which have been reported in these districts. So as also we know that against the 7 HBNC visits, we have financial implications also. So this need to be taken, means checked very carefully whether if this is correct, then this should not be correct. And if you have less number of home deliveries, then how come you give more figure for 7 HBNC visits? And for these visits, state might have also paid for ASHAs also. So this is a very serious issue actually. So we have also call out some C-sections rate against the at night time. How many C-sections was connected? So these are some DH and districts in which the DH are reporting some C-sections for during the night also. So this is very good that yes, we should know that out of how many districts which are giving the C-section services, whether they are actually operating during night also, or whether they are doing this. So that also we need to check ecologists are available around the clock or not. So this kind of data triangulation we can also do with the our human resource module of infrastructure format by looking at the C sections and a number of the gynecologists during the that particular month. So for Goa, see number of women tested for syphilis. So suddenly we have seen that in November we got a 0 figure and December that was not reported. So this also need to be checked. Then again in South Goa, another CHC which has reported suddenly 0 figure in August, and in September the figure gone again high to 92. So after August, the figures are likely to be consistent. Next. Same issue which I have already discussed. So these cannot be justifiable because the services which are to be given to girls and boys against the registration, that cannot be means same as that of what we have registered in that particular facility. Next. See, for this particular facility, even though it is private facility, but again that on particular month, a number has come down to 8. So it might be 80 or 80 plus, means it's my speculation, but it cannot be 8. Next. This South Goa District Hospital. So number of preterm, it was consistently, means some 0, then 22, then 0, 4, 16, 0. So even though we have a similar kind of indicator, number of newborn having weight less than 2.5 kg. So means we cannot say that all babies which have weight less than 2.5 kg, they are more likely to be under the fall under the category of preterm newborn. But yes, this need to be checked whether these are truly 0 figures or there are some other figures. Next. Same case for North Goa District Hospital. C-section. So during night time only means more than 10% we are doing the C-section at night time. Next. Ladakh. See, huh? Yeah. So is it the same that the institutional deliveries are conducted during the same month and the same figures are reported against that 6 HBNC visit in that particular month only? So that need to be checked.
Because the deliveries are happening in
Same visit cannot be, same number of visit cannot be done in that same month.